So good morning to all of you, and today we will going to learn about normal sexual behavior. What is there in the lecture you will see. So psychosexuality is the part of psychiatry, and because of some patients come with the complaint of psychosexual issues, and it is the different branch from obs and gynae which deals with the infertility, and the urology department which deals with the uh, other problems of urogenital system, and psychiatry deal with the psychological aspect of sexuality. So why to discuss psychosexuality? The question is what nature wants, why there is sex between uh, animals, birds, human beings, and even uh, plants also. We have two gender, male and female. So what nature wants from both the sexes? Have you do you have any guess or idea why there is two? So the nature only wants the procreation. So that's why there is male plant, female plant, male bird, female bird, and we also the part of kingdom Animalia. We have also female gender and male gender. So the basically nature wants procreation. The species should procreate and move on and make a cycle of their existence. So what is the difference between human versus others? The psychosexual aspect in humans are different from uh, somewhat different from other species. For example, they have a explorative attitude towards the psychosexuality. That is also known as sexploration. They are more of experimental. They are satisfaction oriented. So they do not have intercourse because of the uh, only for the procreation, but for the satisfaction also. They seek satisfaction. The patients come with problem of satisfaction in sexual issues. Further, it is recreational. Some people have paraphilic orientation also. You will learn in the different lecture about the paraphilia, and we also have now notified community of LGBTQIA. These people also recognized by the law of many countries and considered normal in terms of their orientations, which is somewhat lacking in the other species. So what is normal other than psychosexual issues? This normal can be applied to any aspect of the human being. It may be considered as a health. If a person is healthy and devoid of any psychopathology and devoid of any physical problems, considered as normal. As utopia means in terms of uh, prevalent of such traits or factors which are more available in the society, we consider it as normal. It is also measured by the statistical means. As an average, if the thing is average, then considered as normal. And some people consider normality as a process, and it cannot be cross-sectional. The normality is a process, and in a different situation, the functioning behavior and attitude may differ. In some situation, it is different and in any other situation it is different. This means for the context of any particular situation, behavior may be normal, which may be considered abnormal in other situations. So there is a term statistical nicety. If you will see the bell-shaped curve, there is 95% of confidence limit, in which the 2.5% people from ext, uh, extreme deviations are cut out from the normal, while you are considering 95% confidence limit, and considered the people under the bell shape is normal, and the extremes are not fall in the definition of normalcy of that bell shape curve. So here are some statement. You can see that it cannot be and must not be normal to be a cruel just because 95% of your community is cruel. This is one example. If for suppose most of the people have a uh, tendency of cruelty and a few people are not, so this can't be considered as normal by those people who do not fall into that percentage. And similarly, it cannot be and must not be normal to be attracted to someone of the opposite sex just because 90% of general population is heterosexual. And this is in the context of LGBTQIA community. So the person with different orientation may also be considered as normal because they have such a kind of orientation to uh, not for the opposite sex, maybe for the same sex. The third one is it cannot be or must not be normal to own slaves just because all the landowners in your state is in your state own slave. Okay. So majority is not equivalent to normal. If majority of people are doing such a thing, uh, may not be normal, and this is considered in political orientation also. If you have the one ideology, the other ideology may differ from your ideology, and both the ideology are normal for them. Nor it mean free of discomfort as if normal were the equivalent of oblivious. If you are careless, you are not aware of things, and uh, you are free of discomfort, it also not mean that you are normal. So here is the difference between sex and the psychosexuality. The word psyche has a different meaning when you use the word with the sexuality. So for example, sex may refer to the physiological and psychological process related to procreation and erotic pleasure. This is the sex. And what is psychosexuality? Psychosexuality encompasses all the aspects of sexual behavior, including gender identity, orientation, attitude, and activity. You can see the picture on the right lower corner. The sexuality encompasses the the values one have, the communication style one have with the partner, the image of self, the gender, how they socialize. The socialization is also a part of psychosexuality. How they express physically their gender. This is also part of sexuality. Body image and personality. So we can say that psychosexuality is not only inside the bed, it is outside the bed also. The values, the self-image, the socialization, and other aspect of behavior also makes the psychosexuality. This is the definition of normal sexual behavior. Normal sexual behavior brings pleasure to oneself and one's partner, involves stimulation of primary sex organs, including coitus, often leads to climax. And adding to it, it is devoid of inappropriate feeling of guilt or anxiety, and it is not compulsive. So I have highlighted the word pleasure. So this is not equivalent to satisfaction. The word satisfaction can also be used, but it is not about the satisfaction, it is about the pleasure out of it. So this is the definition of normal sexual behavior. Now, can you guess the sex organ, which is the main sex organ, which is present in both male and female? Yes, yes, brain. So sexuality arises from the brain, and the execution of sexuality is by the means of sexual organs, external sexual organs. But whatever the person is uh, gaining from it, fetching from it, is because of the brain. So it is determined by anatomy, physiology, and the culture in which the person lives. Adding to it, relationship with others, their developmental experiences throughout the life cycle. It includes the perception of being male and female, which is a gender identity, and their own private thoughts and fantasies, as well as behavior. And to the average normal person, sexual attraction to the another person and the passion and the love that follow are deeply associated with feeling of intimate happiness. Recreational is also a part of psychosexuality. It is normal in some context, and as opposed to relational sex, to include casual, premarital, or extramarital activity. If it is not in the abundance in one's life, then in some context it is normal. Societal understanding of what defines normal sexual behavior is inconstant and varies from era to era. So social aspect of our like society, what the norm society follows, different culture follows different norms. Some are more liberal, some are more stringent regarding the psychosexual issues. Even in some society, discussing the psychosexual issues is not allowed. While you will find one other societies are more liberal in discussing the issues. Again, nowadays, significant developments in the field of sexuality include study of sexual behavior in older adults that have helped bridge the taboo against the sex in the elderly. So, elderly, the old age life is also considered being considered for good sexual health and the things to be addressed and should be treated or managed because uh, the notion that वो हमारे यहाँ क्या कहते हैं कि पूजा पाठ करने के दिन आ गए ना भजन करने के दिन है तो सिचुएशन इज नॉट लाइक दैट द ओल्डर पीपल कैन ऑल्सो हैव ए गुड सेक्सुअल हेल्थ एंड गुड सेक्सुअल लाइफ सो that age group should also be considered. So sexuality have a biopsychosocial model in which the biological factors like age, gender, genetics, and other aspects of biology and psyche of the patient and the society in which the person lives all together make psychosexual issues. So we can say psychosexuality is a assimilation of anatomy, physiology, the culture, relationships, and the experiences. So, psyche and sexuality is not equivalent to intercourse. Both are the different thing. Intercourse happens only inside the bedroom, and psyche and sexuality, it is always present with the life of the person. So we will discuss anatomical and physiological basis in the brief, and you have gone through these uh, anatomy and physiology of human beings. So I won't dig deeper into this aspect. Okay. In anatomy, we all know the external genitalia of both male and female uh, have some organs which is primarily known as sex organs. In males like testes, penis, scrotum, and in females like labia majora, minora, clitoris, or other anatomical organs. Yes, this is the G spot, you know, most controversial and most discussed anatomical part. You can see in the picture there is a yellow dot on the anterior wall of vagina which shows the G spot known as Grafenberg's spot. So it is approximately in 1 centimeter in size. Regarding this G spot, what is known is it becomes engorged during the sexual stimulation, and many reports highly pleasurable area, and in some it can induce orgasm. And Grafenberg believed that the tissue here was analogous to the prostate and might account for the spurt of fluid during the orgasm, similar to male ejaculation. Some women state that vaginal orgasm is different experience for them, providing different sensation than a clitoral orgasm. One explanation is that their pleasure is enhanced by the sense of closeness engendered by the coitus. This is regarding the sexual position. Another hypothesis is that these women climax in response to coital stimulation of the G spot. So it's a controversial anatomical spot. Few schools of thought that it exists and some deny it. Here is the physiological response of sexual cycle in females. There is a phase of excitement, and then there is you can see in the white line there is plateau, and then orgasm. There is two orgasm, and then period of resolution. So females can have different responses during the cycle. Here are the four examples. In the black line, you can see that there are multiple small orgasms, then resolution. In the red line, there is a strong orgasm, then resolution. And in the white line, there is a plateau phase and phase of orgasm and then resolution. In the male, there is a part of excitement, then there is a plateau, the sustainability of that excitement, and then orgasm. And in the dark gray area you can see the refractory period, and after refractory period one can achieve the another sexual cycle and can have orgasm. In the refractory period one cannot have the excitement again. So this refractory period may vary from minutes to days. Some people feel like after 5 minutes doing the another act, and in some people they may take few days, 2 days, 5 days, or 7 days also. So now we start the psychological aspect or psychosexual aspect of learning of sexual behavior. So as I have said that the sexual behavior itself starts in infancy and childhood. The examples are uh, the sexual learning in childhood is adversely affected by uh, sorry. So in infancy and childhood, the one can see that an infant starts exploring his body parts like mouth, eyes, and uh, the infant used to explore his body areas, and sometimes when they grown up and have teeth, they used to bite their finger also, and they started crying after biting. So this is the part of exploration. In a similar manner, infant explore his genitals also, and find it pleasurable, and uh, and repeat the activity again and again. They can also learn the behavior by their parents, how they are behaving with each other, uh, their intimate behavior, you know, or maybe in the uh, night time in bed also. So if a sexual learning of childhood is adversely affected by exploitative and abusive adults or incestuous activity, with or without penetration or sexual abuse may result into the damaging the child's behavior in psychosexual aspects and other psychiatric aspects also. The person may develop introvert personality or avoidant personality or maybe uh, anxiety disorders also. So it can precipitate sexual dysfunction in adult life as well as promiscuous behavior or problems in intimacy with the partner. And it may produce delinquent activities and behavioral problems in adolescence as well as learning problems in school. So this is also the aspect of psychosexual life that may lead to some other problems in adulthood and adolescence. Some children are inappropriately stimulated short of outright incest or genital fondling, and they are the, you can say they are the objects of extremely seductive parents and termed eroticized children. They frequently become sexually precocious. So how the, you can say the family is also a part of society. So how society is influencing the behavior of a child. Children who view the primal scene, the term Freud used to describe a child seeing sex between their parents, may be traumatized. This is particularly the case if they interpret coital sound and movements as physical aggression between the parents. Now, what happens in adolescence? There is upsurge of sex hormones and the development of secondary sex characteristics. Uh, Masturbation starts at this state, and they also may start caressing and kissing with the partners. Sexual play, other than penetrative sex, sexual play may also be there uh, between the peer group. And once body image becomes more definitive and sense of sexual adequacy and sexual desirability begins to develop at this stage. So they are more definitive in their gender identity, whether they are male or female, or sense of adequacy, sense desirability starts at this age group. What happens in peer group? Peer acceptance by the same sex and by the opposite sex is of paramount importance at this stage. Engaging in sexual talk and jokes, kissing, stimulating genitalia, experimenting with the degrees of nudity, and experimenting with different partner or with one partner are part of process of learning about the sexuality. And more or less, this happens at this stage. Uh, Joking, experimenting, the in the adolescence period, when they are not fully known about the sexual process, they may do such a kind of activities. These experiences reinforce the adolescent's sense of being sexual, male or female. Okay, so they got to know whether they are male or female by their identity. First coitus may happen after gaining the puberty, and it is a rite of passage of both sexes. And the young man experiencing intercourse for the first time is vulnerable in his pride and self-esteem. So this is considered as the first coitus is it may be a cause of a disorder known as performance anxiety. The person is not able to, it is almost happens with the every person who is going to have sex first time. I mean, he will not perform uh, perfectly. So this imperfectness may lead into his mind, and he may discover himself as a having some kind of sexual disorder. This is known as performance anxiety. So any kind of activity which requires experience, it takes time. So young male and uh, the males who are recently married, they may trap into this situation and they may consider themselves as ill. But uh, as this activity requires experience, and other activity which also require experience like swimming, cycling, it requires experience, and you will become perfect by the time and by your practice. So at this stage, one can have uh, performance anxiety disorder. So cultural myths still perpetuate the idea that he should be able to have an erection with no or little stimulation. As the information gathered by uh, the colleague who are recently married, a person get to know that the first night should be a perfect night, so this is a myth. The information the person who is getting from other person uh, is maybe his overstatement. Might be that informer is also had the problem of performance. He may project himself as if he is a uh, perfect in sexual activity. So by such a way, in such a way, the myths and misinformation are spread into the society. Similarly, pressure on the woman with her first coitus reflects remaining cultural ambivalence about her loss of virginity despite the current era of sexual liberty. Young women with the history of masturbation are more likely to approach intercourse with positive anticipation and confidence. Studies have shown that young women are more likely to enjoy the first coitus if it occurs in the context of a positive emotional relationship. What happens here is, with the females, this is not considered good if they express their psychosexuality. Yeah. They have to remain in the boundary. In our setup, uh, the females are considered to remain in boundary, not to express their psychosexuality. The psychosexuality projected as bad for females. So females are not very open at this juncture. And society, for the year, society made him uh, considered it as a sin. If a female considered it as a sin, that feeling of sin cannot go suddenly on the wedding night. So female may be afraid of or anxious of that activity, and she may not take active part in the activity. So this may lead to discord between the two. In adulthood, by their late 20s, 70% of men and 85% of women have formed a union, either exclusive cohabitation or marriage. The sexual impulse is catalytic in forming and maintaining adult love relationship. Ideally, a mature sexual relationship encompasses the capacity for intimacy and love for one's partner. A sexual excess ceases to be problematic. More attention is focused on activities itself. So they have made a union. The partner is available whenever they have a hormonal upsurge and intense requirement of release of sexual tension. They have available with the partner after marriage. So what happens immediately after it? They are more into the pursuit of career, child rearing, and other family and community obligations. Nonetheless, studies reveal a much higher frequency of sexual interaction among a married person than among single person. The modal frequency of married person is 3 times a month, with many couples relating sexually twice a week. The highest frequency of sexual interaction in studies are 4 or more times a week exist among cohabiting couples. So this, the first one is important uh, because in the initial period of their cohabitation or their unity, they are more focused on sexual activity, and later the uh, things related to career, child rearing, and other family obligations are added into it, and they have divided focus on various aspects of life. So this may also hamper the sexual life. So in general, a graph of sexual practices does not form a bell curve. Most curves of sexual behavior are strongly skewed, with many persons indulging in a particular behavior, conversely with very people doing so. So you can say that nothing is normal by the rules in psychosexuality. What a couple likes, what a man like, what a woman like, his wishes regarding this activity individually be considered normal. In middle age, frequency of intercourse may decline, may devote much of his energy to the career, de-erotization of women because of her wife-mother role. Now, this is what happens when one live with a partner for a long time. They have developed a relation which is more a wife mother role for a male and father figure role for a female. They become like जैसे सोसाइटी में कहा जाता है कि 7-8 साल बाद तो भाई बहन जैसे हो जाते हैं, है ना? तो दिस रिलेशनशिप leads to familiarity. Long relationship leads to familiarity between both, and this may also lead to decline in the frequency of sexual activity. So biologically also, man takes longer to reach orgasm. He has a longer refractory period and requires more stimulation to achieve erection. What happens at the middle age? So this is all because of the biological aspect. At this stage, female must adjust to the hormonal fluctuations of her perimenopausal years, and she too requires more stimulation to become aroused. However, middle age is the period of rising extramarital activity. At this stage, somewhat intimacy and love uh, turns into boredom. Okay. So they need extramarital affair for more excitement and more variability in their activity. So this is the period where extramarital activity may be more frequent. But the data shows that 75% of men and 85% of women remains faithful throughout the lifetime of their marriages. So quantity of this affair is very low according to the data. Now comes to the older age. So in the last 2 decades, the coitus has also been a part of sexual repertoire of elderly adults due to the development of drugs like sildenafil, which facilitate the erection in men, and hormonally enhanced cream or pills which counteract vaginal atrophy in the postmenopausal woman. So physical barrier are managed by the medical treatment. Maybe older people are more by the mind they are interested, but physical health is not allowing them. So the treatment like this may help them to lead a healthy sexual life. So this is also a part of assessment also while dealing with the older people. This aspect should also be considered uh, for your assessment. So prior to the development of these drugs, and still today, many elderly adults enjoy gratifying sex play exclusive of coitus, and this is a myth that older people are not sexually active. An aversion to the idea of sex in elderly persists in today's culture. So as I have said before, so 70% of men and 20% of women over age of 60 years are sexually active. And the physiological changes may include a longer time of erection to occur, decreased turgidity, and ejaculatory seepage. Maybe the problem, but still they are active. Active. Similarly, in females, the problems of lubrication and atrophy is associated with lower estrogen levels, and comorbid illnesses, chronic illnesses, almost is the part of this age group. Having long-term diabetes, long-term hypertension, and we know that the antihypertensive known to cause decrease in libido, decrease sexual desire. So Physical problem may be the hurdle for this old age group. Yeah. So this was about the what happens during a life cycle of a human being, and we will discuss now the psychosexual factors a person have, okay, on the basis of which uh, we have certain kind of disorders in psychosexual issues. So we have four factors. The first one is sexual identity, then gender identity, then sexual orientation, and the sexual behavior. Okay. So these factors affect the personality, growth, and development and functioning. And again, sexuality is something more than physical sex, coital or non-coital, whether it is coital or non-coital, and something less than the all behavior directed toward attaining a pleasure. So the sexual identity is defined by the genotype. If it is XY, then it is male, and is XX is female. This is biological identity by means of genotype. What is gender identity is uh, in infants with an unambiguous sexual activity, almost everyone has a firm conviction that I am male and I am female. Our environment also let them learn whether you are male or female. When we address to female, so we used to the gender specific words to address her, like तुम कहाँ जा रही हो ना, अगर मेल से बात करेंगे तो तुम कहाँ जा रहा है ना. So this lead to differentiate in their mind that they are male or female. So considering themselves as male or female is gender identity, and this identity may not match with this genotype sometimes. So in this picture you can see a male is seeing himself as female and female is seeing herself as male. So this is gender identity. So if a male consider himself as male, this is also gender identity, and if male is considered himself as female, this is also gender identity. We all have our own gender identity, how we consider ourselves as a male or female. With the gender identity, there is gender role. They consider themselves as male or female. Now, how they uh, express themselves, how they dress, how they talk, what attitude they have. So this also reflects their gender identity, what kind of role they are playing. So if gender identity is not matching, then one will find that the male is somewhat behaving like a female, and female is behaving like by attire and dressing and uh, their style of walking. So they may attain the role of a male. This is gender role. Now is the orientation. Sexual orientation describe the objects of person sexual impulses to whom they are attracted. If they are attracted to opposite sex, it is heterosexual. For same sex, it is homosexual, and for both, it is bisexual. But there are more orientation than these three, and are considered in uh, the umbrella term of LGBTQIA. Okay. We will have the separate lecture for LGBTQIA. We will understand what is the aspects of this. And then the sexual behavior. The behavior includes desire, receptivity, fantasies, pursuit of partners, autoeroticism, and all the activities engaged into express and gratifying the sexual need. Okay, this is sexual behavior. What kind of behavior one person is expressing, and what they are doing to uh, get the gratification from sexual needs. It's an amalgam of psychological and physiological response to internal and external stimuli. One behavior may result from the internal stimuli of just fantasizing about the sexuality, or it may be due to external stimulation like watching movies or watching a beautiful girl on a street. So coming to the Freudian viewpoint, this is also important because he gave the theory which is known as libidinal theory, and he related many a uh, disorder and many a behavior with this sexual aspect known as instinct or drive theory. So one example is uh, when there is increase in sexual tension, this will lead to increase in libido, and that results into the intercourse as a normal outlet. Okay. As per his theory, this happens in a sequential manner. So, according to Sigmund Freud, libido is that force by which the sexual instinct is represented in the mind. Na? But this is misinterpreted by some people that it is related to sex, but his concept was not related to sexuality only. Libido, his libido was not equal to sexuality. Okay. What was that? The general notion of pleasure and sexuality, and when it is combined with physiological underpinnings, and it results into the mental representations. Okay. We will understand by this example. So again, there is increase in the sexual tension, and he remain abstinent from the sexual activity or may practice coitus interruptus. What is coitus interruptus is while doing the sexual activity, ejaculating outside the female sexual part. Okay. This coitus interruptus. This is leads to libidinal blockage, and this blockage leads to anxiety, neurosis, neurasthenia, hypochondriasis, and other disorders. So I can remember that when I didn't know the Freudian viewpoint, and in emergency posting, the patient of hysteria, known as conversion disorder or uh, dissociative disorder, presented in the emergency, and the notion was that this is because of the sexual deprivation. In the mind of seniors, it was they were belong to emergency medicine, internal medicine, and this is the libidinal theory is misinterpreted as it is because of the actually because of the sexual part, but it is not. Okay. So stages of psychosexual development he gave. Okay, here are the few points of Freud. So based on his theory of childhood development on the belief of sexual energy termed libido was the driving force of human behavior. So this libidinal force is the driving force of human behavior, and this behavior may be different kind of behavior. He proposed that children progress through these 5 stages of psychosexual development. He gave the 5 stages of psychosexual development, and psychopathology results when a person has difficulty making the transition from one stage to next stage, when a person remains stalled at a particular stage or regress to the earlier stage. He gave the 5 stages, and according to his theory, he believed that this libidinal thing, when the person is fixated at the particular stage, may lead to some kind of behavior or disorders. So this is these are the stages. The first one is oral phase, which is from birth to first year, and the erogenous zone is mouth. So at this stage, usually infant plays with his mouth, plays with mouth, try to grab things from the mouth, try to experience the thing with the taste, whatever it is. He tried to put anything into the mouth. So he defined this as a oral stage. Okay. So consequence of physiological psychological fixation at this oral stage may lead to orally aggressive person, which may be shown in the behavior of uh, prolonged chewing the gum and nibbling the end of the pencils, etc. And orally passive behavior like smoking, eating, kissing, oral sexual practices may lead because of this oral fixation. And it may also result in passive, gullible, immature, manipulative personality. Then he defined the anal stage, anal stage from 1 to 3, the bowel and bladder elimination. When the person started, the child started have some kind of control on it, and there is two type of fixation. One is anal retentive and anal expulsive. When the person is fixated in retentive type, he may it may lead to obsessively organized or excessively neat kind of behavior in the person. And when it is expulsive, he may become reckless, careless, defined, disorganized, or coprophiliac also. The phallic stage is from 3 to 6 years. This is genitalia stage. And in this stage, he explained a Oedipus complex in the boys, and counteracting this Oedipus complex or equivalent to this Oedipus complex, Carl Jung has given the idea of Electra complex. We will learn in the next slides regarding these complexes. Then there is a latency period, which is from 6 to puberty, when the person gains the puberty. This is dormant, erogenous zone is dormant sexual feeling. Sexual feelings are started developing at this stage for another person. And fixation may lead to immaturity and inability to form fulfilling non-sexual relationship as an adult if fixation occurs at this stage. So non-sexual relationship means the relationship out of the sexual activity, the person may not able to form this. And then this is the genital phase, which is puberty to death. The sexual interest matures. This may lead to, the fixation may lead to frigidity, impotence, perversions, great difficulty in forming a healthy sexual relationship with another person. So these are the 5 stages he defined according to his mind, and which is rejected by the other schools of thought that this is not the true. So coming to the Oedipus complex, what is Oedipus complex is, uh, the Oedipus complex refers to a son's sexual attitude towards his mother and concomitant hostility towards his father, first formed during the phallic stage of development. And the complex thought to persist into adulthood as an unconscious psychic structure, which can assist in social adaptation but also be the cause of neurosis. So Freud considered that the child identification with same-sex parent is socially acceptable outcome of the complex, uh, while for the opposite sex it is not acceptable. The theory is named for a mythological figure, Oedipus, from where the theory has came. A mythological figure, Oedipus, an ancient Theban king who discovered he has unknowingly murdered his father and married his mother, whose depiction in Shopkill's Oedipus Rex had a profound influence on Freud. This depiction has an influence on the Freud's mind, and it came from a mythological figure. It is not true. This is a mythological story from where he was impressed. In contrary to it, Carl Jung gave the concept of Electra in 1913, and is proposed as equivalent complex among the girls as for the Oedipus complex. It is a girl's psychosexual competition with her mother for possession of her father. It is also came from a Greek mythological character Electra, who plotted matricidal revenge with Orestes, who was her brother, against Clytemnestra, their mother, and Aegisthus, their stepfather, for their murder of Agamemnon, the, her father. है ना? So Freud rejected his Electra complex, and these were the developments at the time when uh, we can say the era of uh, when we started looking the things scientifically. All the science were developing along with each other. Like uh, someone has discovered that sun is not revolving around the earth, and earth is actually revolving around, and other theories are developing, like Newton uh, and other scientists. So psychology was also developing their ideas and generating their theories, though this is out of that era. So without this understanding this uh, concept, one cannot move further into the psychology. And although these are the rejected theories, and nothing has been found in the structured um, clinical trials that this is this is the situation. Other than these uh, theory of Freud, the other main developmental theories are Erickson's model, behavioral child development theory, Piaget cognitive developmental theory, Bolway attachment, Bandura social learning. So these are the developmental theories, uh, maybe revolving around other aspects of human life, but psychosexuality is a definite part of human life. So these theories also discuss the psychosexual aspects, but not as the libidinal theory of Freud. So in the end, what is normal? So normal sexuality is a complex and subjective concept that depends on various factors such as biological, psychological, social, and cultural aspects. So when we look for a normality of an individual, we should consider all the aspects, his or her biological aspect, their psychological aspect, what they think, what the society of his or her thinks, and the cultural values in their society they have. So we look upon into it also while assessing a patient with a psychosexual issues. So today we are going to discuss about the myths and misconceptions regarding the sexuality. Hmm. A lot of patients will come in the clinic with the notions and misconceptions regarding the psychosexual aspects. So first of all, we will discuss from where these misconceptions are originates. So there are certain factors such as the topic is less discussed among the youth and considered as vulgar and obscene. The aspect is considered extremely secretive and unacceptable. The information then comes from self-learning, from friends, those themselves are not aware of the facts. They have been misinformed by the immediate elder ones or other persons like friends, and they move to the quacks, and they trapped in the information of myths. So how these myths are present in the society. So we will take the session in a question answer form. The first question is, do men want sex more often? So this is a misconception. So for your understanding, sexual desire varies from person to person, both men and women, but it is not always true that male always want more frequent sexual activity. So being member of the same species, both have the sexual desire, may vary slightly but have similar one. So another aspect is women involve more in the emotional aspects in the sexual context. That's why their sexuality uh, is not so much expressed, and they may be considered as having less sexual desire. Openness also does not translate into being able to express their own desires, as we had discussed the upbringing of the females, how they are restricted and uh, not considered so much good if they are pro in their expressions. So they do not express their own feelings. That's why it may be portrayed as they have less sexual desire. So again, the thing is, they may consider not socially acceptable if they are expressing their sexuality, and this is viewed with the stigma from the both sides of the society, men's and also the women's are having viewed this expression as a stigma for their female part only. Everyone in the couple should be able to discuss their expectations to overcome this discomfort level, and uh, they may need to strengthen their communication regarding the frequency. So normally a man may feel normal having sex with any woman he meets, but a woman needs to develop emotional unity with him in order to accept. Once the unity is accepted, then this may lead to uh, more desirous for intercourse. So this is the subset of question within this aspect of frequency of more sexuality. The men think about sex every 7 seconds. But if you look for transformation of this data into actual data, it comes out to be nearly about 8,000 times a day, which is not very obvious or not very logical. In a study which has been done on the thoughts related to food, sleep, or sex for a week, then the average time for male was 19, and for female the average was 10 times per day. And this they also reported that they thought about it based on the overall needs and not out of the blue. The second one is most believed thought that masturbation is harmful to health. The patient may come with this thought in your clinic. And regarding the masturbation, it is to achieve self satisfaction by stimulating the genitals using hands or any other object and achieving the orgasm. It's a natural process, normal, harmless sexual activity. There is nothing to be ashamed of or afraid of. It is not a harmful activity in itself, but the guilt and shame associated with it, believing it to be harmful, can be harmful. What happens is, the myth is that masturbation is harmful to health, and a person came across the discussion that with others that uh, or very first time he came to know that masturbation is harmful to health, and he may start believing because of the most of the people are saying that, discussing that, and believing that. How this myth develops that masturbation is harmful. So it's a normal process. Any other type of sexual activity is neither uh, highly discussed or condemned, or it is no, or nor it is more practiced apart from the masturbation. It is the most discussed issue among the youngsters, and according to the research, almost all men and three-fourths of women masturbate at some point of their lifetime. And if it will be true, then it would affect almost all men, which is not true. So if would be harmful to having this activity, this means your kidney will be rushed by all these males who are masturbating. So it cannot be true for obvious reasons. So another aspect is when the onset of puberty is there, there are increased hormonal activity and development of secondary sexual characteristics, and which leads to increase in sexual curiosity, and masturbatory activities increases. And this is due to our social norms also, because of the social restrictions and non-availability of partner, and restrictions from uh, meeting with the opposite sex because of the societal boundaries. So partner is not available, the sexual tension rises, and it leads to or ends with the masturbatory practice. So this has nothing to do with the weakness or other thing which is associated with the this practice. And again, with the psychological point of view, it plays an important role in establishing gender identity, as you know, and adopting gender role in adulthood. So another fact regarding the masturbation is it is not completely given up by the couples being married, and at some point of time they used to do this practice because of uh, maybe of because of the partner is not available, or the previous sexual session was unsatisfactory, or it is a way to relieve sexual tension if when availability of partner is not there. So it is a morally prohibited act, and it is a notion that masturbation causes physical weakness, reduce fertility, and people may also come with the notion that the bulging of veins on their extremities because of the this practice, as told by their fellows. So masturbation is not under the control of the person, it is done out of the necessity and is not being done for pleasure. Then it can also be symptom of some other disease. If it is not in control, if it is a compulsion to do it, and guilt is associated with it, and it is not being done for pleasure, or it is done for as a obsession or compulsive act, then it cannot be a normal process, otherwise it is. Another related question, excessive masturbation reduce the penis size. This is also a common myth and misconception. So obvious for the reason, no amount of masturbation can reduce the penis length. It is the perception due to their out of their anxiety or their worrisomeness, because it has been told by the others. What happens is when you are more anxious about some aspect of your life, you see you can see some kind of abnormality when which is not there. And this also happens because some other physical reasons, that if one have to look for his genital, then he have to look downwards. And if you can think of, while you are seeing the objects from an aerial view, the things are uh, looks smaller. If you looking from a higher height, or if you are looking downwards from a flying plane, aeroplane, then you will find that the things are actually looking smaller in the size. The one other reason is obesity. While the person is obese and he is looking at his genitals, may found that it is reduced in size. So all the factors accumulates and uh, can be the person can perceive the size of his penis is smaller. But it is not true that excessive masturbation reduce the penis size. Some questions are there related to the semen. The questions are, it's a very important and precious substance, and every drop of semen is made up of 50 drops of blood. Loss of semen through masturbation causes weakness or other illness. The amount of semen in the body is limited. If you ruin it by masturbating, soon will you get over it. It will be exhausted. It will be over. So these are the thoughts are actually there. You will find as a counselor, sexologist, or psychiatrist. So what the truth is? How will you analyze the situation? If you will ask the person that it has no relation to the blood, and you can correlate the other fluids which are excreting from the body, and you can let him think that you are not bothered about it, like saliva, tears, and sweat. These are also the fluids. These may also be made up of 50 drops of blood, but you are not bothered about it because you have been told many a times that this is the fact. You have understood that fact as that myth as a fact. So blood provides nutrition to the testicles as it does to the other body organ. You can explain. It is not certain that some amount of blood is used for production of semen. Blood is meant to provide the nutrition to the all of the body parts, not only the testicles, for converting volume of blood into the semen. Again, you can confront that the semen or ejaculatory fluid is a mixture of secretions from prostate gland, sperm, and fluid from the seminal vesicle glands, etc. So what you are seeing as a semen is mixture of different fluids and collected at one place and is ejected. Then for this reason, the part of semen is not coming from the one section, it is coming from the multiple sides. So the 50 drops of blood cannot be converted in that manner also. If it would have been, then the one only and one part will be the origin for the semen. So regarding the stock of semen, they may think that they may have notion that it will exhausted and it will be get over. So you can explain that it is not limited because everything in your body is in a dynamic phase. It is not in the static. Even everything is in the dynamic phase. The physical part of all this world is dynamic, like flowing of water, so making of Himalayas, still it is on the rise. It is still in the form of making. So the other body parts like your hair grows and falls, then you have a haircut. So likewise, semen is not a limited thing. This is an ongoing process, and when it is informed adequately and because of hormonal tension, uh, you have a sexual tension, you relieve it by doing sex or masturbatory practice, or it may ejaculate during the night as a nightfall. So after this your body starts again making the process of this semen. So it's a normal physical activity. This is man is able to achieve erection whenever he wants. So some patient will come with this problem that they are not able to achieve erection very easily, not all of the time. So what they think that they are not normal. So this may have various reasons, like there may be difference in hormonal peaks of the couple, while the female is on the peak and male is not, he may not get the erection. Decreased desire is lowered because of other reasons. Unsupportive partner, if partner is unsupportive during the act, then may not get the erection. For example, if you had an altercation with your partner uh, on that day, and you are supposed to have a good or fruitful sexual activity, may not be possible. And if it is a new partner, like new partner in case of marriage also, the one can have temporary erectile dysfunction. Lack of privacy at the place of intercourse, and others like excessive daily stress may be the reason for non achieving the erection. So if you ask them when you had a good erection or sexual activity, how was that day? Regarding all these factors, you can ask. Then you will find that at that day, it was overall a good day. No stress or no tension or little tension was there, and partner was also in cheerful mood. So they did have good sexual activity. If it is not on the multiple occasion, and if it is not continuous, then it cannot be considered as a disorder. And if the person is having frequent regarding this, then one can take for management. Sometimes what happens is they may come with the complaint of losing the erection during the sexual activity. It reduces or ends for a while, and in such a situation, the partner's role is important. Why it happens is your sexual tension is related to the sexual tension in the mind, you know. And in the mind, your sexual excitement may not remain at the same level for whole of the session. Then, if the sexual tension in your mind is reduces at a point of time, then erection will also get loose. So it happens normally in such a situation. The partner's role is important to regain the erection. The partner should help him in various ways, or the man can achieve this again by stimulating himself manually or changing the position. And it is normal for erection to drop intermittently during the sexual intercourse. One should not be alarmed by this. Intercourse lasts a longer time. Some patient come with the problem of prematurity. So ideal sex should last as long as one wants to it to end. Contemporary to popular belief that sex should last hours, many couples enjoy and are satisfied with intercourse that lasts between 3 to 13 minutes, according to this study. Some females find long session pleasurable, while men may find it boring, and often partner prefer it to end quickly. Others enjoy slow. It all depends on when, where, why, and how you have sex. So for the timing, there is no rule. This is the individual satisfaction. Uh, one may be satisfied with the shorter period of time, one may be for long. And from where this myth or misconception comes, uh, when some fellow exaggerated their experience to the patient may think that the duration of mine is low. While that fellow person may not have that much of uh, longer session of the sexual activity, he may be exaggerating his own shortcomings. You know. So some says that half hour and 45 minutes and 1 hour, and which is not true. A whole session can be of half an hour, but penetrative sexual activity cannot sustain for that longer period of time. So you have to counsel and you have to psychoeducate about this timing. For the same question, there is a condition premature ejaculation. In Hindi, it is known as Shighra Patan. And so regarding this complaint of timing, patient describes it in different ways. And if you ask what does it mean, the patient come with Shighra Patan because he has heard that word, he has seen that word written on the walls, on the streets, on the hoardings, on the advertisement, and he himself does not know the meaning, but he find himself as having some problem or disorder. If you will ask what is it, he may not be able to define his problem also. Some correlates it with the orgasm of female, and some come with the problem as soon as the penis enters, and some associate it with their own time, like 3 minutes, 10 minutes, half an hour. They don't have an idea of the bidirectional aspect of the psychosexuality, but they have their own wishes for the timings. So in this connection, uh, what we can say is people view the sex as a mechanical act. That is, they fail to see the sex as a bidirectional process in which mental harmony is required between the couple. It should be slow and balanced onset of sex, and expectations from sexual act. Many other things are also important. But they see this activity only in the relation to themselves only. And it is obvious that naturally all the pleasurable factor will not be present together. So it is an illusion to think that sex will be 100% pleasurable. So for the pleasurable session, all the factors should come together, and it may not happen that all the factors are present at the same time. For example, hormonal peaks of both the partners may mismatch. The day they had uh, from the morning, the person may have stress of losing, for example, losing money, had altercation with his colleague, or there may be a family discord which had ongoing or exaggerated on that day. Though these factors are also important in having a fruitful sexual activity. So for this premature ejaculation, if it is very severe, then sensate focus method can help. This method we will learn in uh, the management part, the non-pharmacological management of psychosexual issues. We have another lecture for this. So it is a universal truth that both will not achieve orgasm together most of the time, uh, but its percentage can be increased by practice in this sensate focus method. Good sex always ends in orgasm. So sexual activity without orgasm is not considered good sex by many couples, and this is just another sexual myth. And perfect sex does not require you to have orgasm every time, and it's a biological peak of sex. It's an part of the whole activity. It is the end of that activity and relieving of the tension, and it symbolizes the completion of the sexual act. On another instance or other instance, many people view sex as a journey, enjoying the activities and sight along the way to their destination, rather than focusing on the end part of it. So you can compare this with when you go for a vacation or summer vacation at a destination. You enjoy the journey also. You enjoy your preparations also. You enjoy while you are going through the pathway or on your way. You enjoy that thing also rather than enjoying the end point. That is also important, but not always. This thing we will learn in Sensate focus uh, as for the premature ejaculation. So this is another sub question of this part. Do all females achieve orgasm during the intercourse? Intercourse. This is not true, as some women experience anorgasmia. You must have gone through the previous lecture of sexual cycle, anorgasmia. And this does not mean that they cannot enjoy sex. There is an end to orgasmic journey, but reaching the point may be more pleasurable sexual journey. Another related question: a female can achieve orgasm only through penetrative sex. For the fact, most females need clitoral stimulation to experience orgasm, and because it is analogous to the glands of the female and most erogenous body part. It also depends on the position in which the woman has sex. Some women achieve this by having sex in certain position, which possibly stimulates both the clitoris and other external genitalia, resulting in orgasm. In this way, the chances of orgasms during sex can be increased by clitoral stimulation. More women do not achieve orgasms through the penetrative sex alone, but it is possible for some. So it is not always, because of penetrative sex does not most of the time does not have contact with the clitoris, and it may be achieved both the stimulation in certain positions. So it is not true that the women achieve orgasm only through penetrative sex. Other means can also lead them to end of the session. So it is difficult or not easy to determine who can have orgasm from having sex in particular type. It depends on every individual that how or what technique or what position leads to this end of the session. And humans can achieve orgasm in all kind of ways. Author of book Bonk, Mary Roach, found one woman who orgasmed just thinking about herself and another who orgasmed while brushing her teeth. And this happens in after childbirth also. Sometimes some female feel orgasmic activity while breastfeeding. Again, we are discussing this G spot. It's a center for orgasm, considered as a spot of controversy. Some school of thought says that it exists, but some says that it is not. Uh, but one can have idea that the anterior part of the or anterior one third part of the vagina is having more neuronal innervation. So this spot is not a spot, but anterior part of vagina, anterior one third part of vagina, which is responsible for having climax or orgasm, and it is said as a G spot. So in again, the most sensitive part is the clitoris, and uh, gives the immense sexual pleasure to the females. Sexual dysfunction is a medical problem only in men because all the advertisement, all the hoardings, all the things you have seen uh, in the society that it is targeting the males only. They do not discuss about the female problems. And if a female has a problem, then she also not come up with easily with their problem to be discussed or to be treated. So they have sexual problems also like anorgasmia, vaginismus, dyspareunia, and others. Or they may also have problem of anxiety, severe anxiety to having sexual activity. Size. So we had discussed about the G spot and the erogenous part, anterior one third of vagina and clitoris, and related to this, this is the male aspect. Does size matters? And even more educated society believes that penis size contributes significantly. Uh, but the fact is that the erogenous part or more sensitive part, it is not very inside the vaginal canal, and the interior of vaginal canal is less innervated by the neurons, and the anterior one third and outer part of female genitalia, the clitoris, the vulva, the labia majora, labia minora are more sensitive. So there is no point that longer penis will certainly will give the pleasure to the partner, but it may be wish of his partner that she likes it or not, like other features like skin color of her partner, like hairs of her partner, like attitude of her partner, like any other aspect of her partner. This may be the wish of hers that uh, the size may be of this length. Another aspect is for sizes, it is not the forceful penetration of the penis that women prefers, but truly soft, rhythmic, soothing, and gentle handling she requires. And this is the notion that this is the misconception that if they will do aggressive or violent activity, then the female will be gratified. This is not true, and this should be understood by the person who is having this kind of notions. So promotional medicines are there in the newspaper and all in all the advertisements, but it is not true that any of the tonic or drug can increase the size or have any effect on the size. So as so again here the same thing is discussed. The inner part of vagina is less or slightly innervated, but outer part is more. And in the last, various researches have consistently found that sexual satisfaction is more influenced by the psychological connection between both, not the shape and size of the genitalia, intimacy and relationship satisfaction, intimacy and relationship, and which satisfy more rather than the shape and size of the external genitalia. When the it is more important when and how two people connected with each other through sex. Do women also ejaculate like men during orgasm? Some person may think that female also have a counterpart like ejaculatory function during the orgasm. This is not ejaculation, rather this is a rhythmic contraction of muscles around the external genitalia, and sometimes in more excitement the females may squirt, which is not semen, but it is just leakage of from the urinary bladder, and it is not the ejaculatory fluid. Here are few sets of questions which are obvious and needs no discussion. Can a woman become pregnant during menstruation? Obviously yes. Can a woman become pregnant only by having sex in lower position? It is also a myth. As we know that uh, the meeting of ovum and sperm is required to get pregnant, whatever the position is not considered for this to become pregnant or to impregnate. Can pregnancy occur through oral sex? Obviously not. Can an adult woman get pregnant just by having sex for the first time? Yes, can have. Any frequency of sex may lead to pregnancy. The patients may come up with this problem also. They have lots many questions. I have taken only the common questions they used to ask in the clinics. Does the withdrawal method work to prevent pregnancy? Withdrawal method is uh, while this is about to climax, then the male ejaculates outside the vagina. This is called as withdrawal method. And controversy is there. Some studies say that the pre-cum contains sperm, which is enough for to make pregnant, and out of the million sperm, even just one sperm is enough to uh, get pregnant. And the study says that this method does not work uh, all of the time. And as for the other contraceptives, they have the failure rate too. Even barrier methods have failure rate too, like oral contraceptives have failure rate, and similarly this activity also have failure rate, um, but may found somewhat helpful in certain situations. So be aware that it is not a 100% safe method. Science of virginity. So nowadays we all know that uh, the membrane may be too lax, may not rupture at the time of first sexual activity, or it may be already ruptured through exercise or masturbation in the past. Therefore, it is not a sure shot sign for virginity to women to bleed during the first sexual intercourse. And ultimately, there is no test to prove virginity. And regarding this aspect, there is you may know that two finger test must have heard in the forensic science also. The two finger test is a test for virginity or habitual sex offender. And recently in 2022, in a landmark decision by Honorable Supreme Court, and they decided to impose a ban on the two finger test. And this and the apex court also warned that anyone performing this test will be held guilty for misconduct. And they considered and they said in their observation that it has no scientific basis, and it instead re-victimizes the victim and re-traumatizes the victim uh, by doing this test, and it has no valid scientific basis, so it has been dropped from the constitution. This is the related aspect of virginity for the legal means. The last sets of questions: during menstruation, a woman become impure and the bad blood is flushed out the menstrual flow. This notion is already or are nowadays also very prevalent, you know, in very religious institutes, religious places, you know. Even in the families, the females are not allowed to enter in the kitchen nowadays also, and not allowed to enter in the temples and other places. Is menopause or cessation of the menstruation the end of women's sex life? Is not true. After menopause, many females are desirous and sexually active, and for assistance, lots of treatment available for them to have vaginal lubrication, like hormonal therapies, and other therapies are also available to continue their sexual life. Vasectomy causes impotence. It has no point to say that it causes impotence. The last question is, can having sex with a virgin woman cure bacterial disease, infectious disease like STDs? This is you will find this is very funny, but it's a very dangerous notion. You are not going to be cured. Rather, you will transfer your infection to the other only. This thing also found in the society. Some person may think like that. And this is more in the connection of HIV. If you have HIV, then this activity can cure you, but it is absolutely not true, and it's a dangerous thinking. So, to end with the session, this lecture, there are a lot many misconceptions in the society. Misconception arises from discussion with various non-expert person, from colleagues, from self-learning, from various material available on the internet, magazines, uh, which may mislead the person to believe the misconception as a fact. Okay. So these points you may discuss with your patient in such a manner that you can bust the myths that this is not true and the actual situation is this. So good morning to all. So till now we have gone through various scenarios regarding psychosexuality, like what is normal psychosexuality, what are paraphilias like LGBTQs, and various other aspects of this issue. So we are going to discuss today psychosexual issues of inexperienced young persons. In your clinic, you may find a young person who are recently going to marry, or whether they are in the casual relationship, come up with some sort of problems. So again, they have their origin of problem from negligible sexual experience, or they had no experience and are often in informal relationship and worried about their performances and often victims of wrong information. So this rise to problem in the young age. The source of information for this generation is generalized thought, their own thoughts and ideas and thoughts of an experienced friend, and exaggerated experience of friends and others, hoardings and advertisements, as we have discussed, internet, magazine, newspapers may also be the source of information that they are having some kind of problems. So in the newspaper, you have seen many advertisements of sexual problems are there, and so by looking at these, they may become uh, worried, or they may found themselves ill about the sexual problems. So these problems may include disorders like dhat, which is so called as the illness or disorder, which is actually not. Wrong information about size of genitals, erection in penis, misconceptions about first sexual act after marriage, associations with their body build, how they look. They are worrisome about the visible veins, because of someone had said that this is because of excessive masturbation or other uh, sexual problem like Dhat syndrome. Eyesight may also be correlated with the uh, sexual issues. So such a things are found in the young generation. But we will focus today on pressure of the first coitus. So it is general notion that the wedding night should be uh, awesome or tremendous. The act will be such and such that your partner will be pleased or will be satisfied. But one thing you will find that when you will ask them the definition of what is the awesome or tremendous, so they are not able to. So they are not able to explain uh, what he or she means by awesome or tremendous. How it will happen, what they are expecting, and how they look for this first coitus. But they demand for a awesome or tremendous sexual activity. So we will understand this problem in two ways. First, in the context of a man or male. So an unmarried or inexperienced young man is told from various sources that his future sex life depends on good performance of the first night. So then he wants to know the definition of good sex, which he does not find anywhere or is wrong. So what the real situation is, it is important to know that the maturing in sexual activity is a learning process, as I have told in the previous lecture also. And this is not something which someone knows beforehand. No one comes from birth learning it. And whenever someone starts doing some learning activity, gradually they become experienced in it and they know about the techniques of it uh, and the likings and dislikings in it. For example, in other aspects of their learning also, like swimming, cycling. So rule of learning applies everywhere, and day by day with experience, the person becomes more mature. But what they think that uh, it should be wonderful on the very first night. So this is not true. But another aspect is very important, which is the matching of mind. Importance of the important is congruency between the mind, the consensus, mental unity, reconciliation, harmony between them, adjustment. So a person who is going to recently marry and you can compare the when one couple make a relationship or in the before the marriage they are in the relationship, they don't straightforward go for sex. No. They usually first the talk is exchanged, then they uh, start spending some good time in leisure time, and then maybe they start holding hand, then hugging and kissing, and one day they may find the day on which they are in the mood of going for sexual activity. So this is the process of mental congruity is establishing between the two. So this is also important part. And how come when the natural process is this, and one man can think that on the very first night, the girl who he started knowing for the last 1 month or so, so having going to have a good sexual activity. So this thing should be taught to such a patient. Yeah. If they are not, they may become nervous or lose confidence or start thinking that they are having some kind of sort of sexual problem. So one should be counseled and psychoeducated regarding the this natural and slow process of bonding between the two. They started blaming themselves and they consider themselves ineffective, sick, and you try to console them and to tell them that do not panic. This happens with everyone, and this is not a illness. So another aspect of it, when we see from the perspective of a female, so the person, a male, who thinks that the first night should be awesome or tremendous. So somewhere in mind, he thinks that he is going to be judged. So he takes it as a kind of a test, and but he forgets that his partner is also equally inexperienced. For her, he is also a new partner. So how can she judge the perfection when she is already inexperienced? When she is also nervous for many reasons, just as a young man learns it over the time and become experienced. Similarly, the female partner also learns and matures by experiencing. So this is a bi-directional. Both have to understand each other and understand the likings and dislikings of each other in non-sexual aspects of life also, not only the sexual aspects. So when they are matched perfectly, then this will be a fruitful sexual activity. So the conclusion is young people often come here who have a little sexual experience before marriage, and this experience for male may have been either with temporary female friend or formal stranger or a paid act. So in such a situation, apart from experience, other factors also affect the performance. Like if they are in the casual relationship or had has little experience, so they have less opportunities for repeated attempts. While the uh, partner is available all the time, then the chemistry is different. But in the casual, this is not always available. Lack of meeting of minds may be the problem. Lack of safe place in casual relationship may be the problem. Indifferent behavior of the partner. Considering a session as a test, so this will also be a problem. Instead of bedroom, doing it in impractical place. So performance of activity may hamper in these situations. So what is required is available partner with whom one is spending his life, his or her life, and they are uh, available most of the time. Consistent experience with each other. Partner is preferred or not. Preferred partner uh, is required. Favorable mood of both. If there is a mismatch of mood, someone is irritable and another partner wants the activity, it will not be fruitful activity. Feeling of enjoying the enjoying the session, not taking it as a test. Availability of favorable location, etc., such as such thing are important. So it is not a physical act only, it is not a one-sided emotional act only, it is a bi-directional physical and emotional activity. When all the factors are matching, the hormonal peak, the mood and the place, and there is relatively no mental tension is there in that day, the activity will be good and fruitful. So today we will discuss the association of pornography and psychosexual issues. The person may come with the uh, point they have seen or what they have learned from the pornography, and they portray those ideas on themselves and are worried. So although it is banned legally, but somehow the person are getting through it, and some may find this as a uh, fun or may as exciting, and some may find this uh, graphy as the material of education. So real life sex is quite different from pornography. How it is, we will going to discuss. So if someone is getting education or try to learn from it, and this means he is getting wrong information about the sex, especially when it comes to please a female partner. So one should not be misled by the pornography, and it should not be seen as a sex education. Okay. So what is the reality regarding these movies. So these movies are filmed in the form of fantasy story, after which we should return to real sex life. Means it's not a documentary. It has a certain features and certain factors regarding production of it, like preparation, editing, and revision, and other normal aspect of making any film to apply. So there is a producer also, there is a director also, there is a cameraman also, and other assistances also. So it's not a real life situation, it is a made situation. So you can compare it with the other normal movies. These movies also have a preparation, addition, revision, and they have also crew member, producer, director. Similarly, this also have the activity is not in the solitary or confined places. It has a different scenario behind the scene. So this is not to be considered as a real life. The actors are also selected on the basis of their specific body parameters, as the body parameters of a normal movie actor is selected by audition. So if some director want to take a villain uh, from the south jungle of South India, then he will take a man who will look like a South Indian man. So this thing is also important in such a movie also. Their height, shape, body, muscular body, uh, the shape of breasts, the shape of male genitals are selected, and this creates a selection bias, understanding the real sexuality. They are also trained for difficult positions, sustainability. So one should not learn that these positions are normal and one can sustain for a longer period of time. And they are performing these actions under guidance. The another aspect is female actors also try to portray fun because they get paid well, while in their real life they may not like such and such activity, but they are asked to do so uh, in the lieu of payment. So they are they may be doing such and such activity. Most pornography is made by men with other men in mind. It is not surprising that the pornography focuses more on men's pleasure than women's. But as I have said in previous lecture, it's a bi-directional thing, and the both equally should get the satisfaction out of it, and this should not be one-sided. So, which is not somewhat seen in these movies. Apart from it, one should not learn or take it as a sex education material, but something which one can learn or one can find a therapist can say such a such thing you can learn from these movies is women require more or less stimulation of clitoris, which is very most sensitive genital organ for arousal. Female need more time to build their arousal. It can be learned. Different sex positions don't always work. Men can achieve orgasm using their hand also. It is not only the penetrative sex. The entire sex, the act is not penetrative only. So, some people focuses on the uh, penetrative sex only. This should be a thing which they want in their life, but it is not. A whole entire act should be considered. The journey is important rather than achieving the orgasm. Conditioning. Some patient come with problem of conditioning with watching too much of porn. While they watch too much of porn, they become conditioned, and they may not get aroused by the less intense visual stimulation. So pornography can be considered as intense visual stimulation. So without it, in normally they are not get aroused while doing sexual activity with the partner. So conditioning may cause a problem of the desire and arousal at the time of sexual activity. So it should not be the major part of, or one should not uh, watch porn while doing sexual activity or masturbatory activity. Otherwise he or she may get conditioned to it. Without it they won't get uh, adequate sexual arousal during the sexual activity. So this is all about the pornographic aspect, uh, which means it should not be considered as a sexual education material, and it's a movie in comparison to other normal movie. It is also have certain features and aspect, and it is not a solitary activity done in the confined room.
Good morning to all. In this last lecture of series of psychosexual disorders, we are going to discuss non-pharmacological management of psychosexual disorders. We will be covering in this lecture the Sensate focus exercise, start and stop oblique squeeze technique, Kegel exercise and psychoeducation. Let's begin with the Sensate focus. So first we have to understand what is sensate. Sensate is relating to the ability to perceive, which is also called as notice or feel things through the senses, such as feelings, sight, etc. The skin is capable of detecting a range of sensate experiences such as heat and cold, and uh, basically the babies are sensate creature that acquires the ability to react to stimuli while they are still in the womb. So the sensate is not just regarding the sexual activity. The sensate is uh, present all throughout the lifespan, and it has a various roles in forming bonding, forming relationships, whether sexual relationship or out of the sexual activity. The Sensate focus was developed by Masters and Johnsons. It helps couples learn about themselves and each other because it's a bidirectional activity, and to move towards more fulfilling intimate relationship. The aim of Sensate focus is to build trust and intimacy within the relationship, helping to give and receive the sensate. It emphasizes positive emotions, physical feelings, and responses while reducing any negative reactions. So, why and for what the sensate focus? The sensate focus works upon reducing the fear and anxiety during the activity, removes familiarity, and introduces novelty. If the relationship is old, there is a monotony which is removed by the sensate focus. It introduces relaxation and problems related to body image, arousal, desire, orgasm, premature ejaculation, and erectile functions are uh, being solved. About the sensate focus not a race to an end. There is no target, there is no goal. Its continuous reinforcement is needed to overcome negative reactions to intimacy. Typically, in sensate focus exercise, there are various sessions, and sessions might last 20 to 60 minutes for a once, and 2 to 3 times a week, spread it over 6 or more weeks, depending upon the improving performance. It is important to go at your own pace. There is no hurry, there is no instruction to go by certain speed, so one can take their own pace to go from one phase to another phase. The ground rules for sensate focus are: one has to ask to choose, A time and place acceptable for both where they wouldn't be disturbed. For the sensate exercise, ask to make the surroundings as pleasant as possible uh, by choosing music, lighting, and aromas which suits the both. Ask to turn off the phone if necessary, lock the doors so there should not be any kind of distraction. Instruct to take turns giving and receiving touch. So this is a bidirectional relationship. Then the involvement of both the partners are important. So one by one they should take turns to give and receive the touch and allowing equal time for each other. The goal is enjoyment and pleasure. Enjoy the journey rather than aiming towards an specific destination. So there is no goal, there is no target. Asked to take as long as they want over each phase. So there is no hurry. There is uh, one can take as long as they want to remain in the one phase before they are comfortable to go in the another phase. Only move from one stage to next when both partners are agreed. The general instructions for sensate focus. When it is one's turn to touch, take plenty of time to explore the partner's body. Experiment with different sensations and types of touch. Take pleasure in experiencing the texture, form, temperature of the partner's body. Ask them to try to discover the degrees of pressure and types of touch their partner finds most appealing. Ask them to give by encouraging feedback or by placing hand under their hand so they can show you what they want. When it is other partner's turn to be touched, make sure he/she let the partner know what you like and what you don't. One can tell their partner how you feel by various means of communication. Avoid saying don't as it can be discouraging. It's more encouraging to say things like it feels better when you do such and such. One might find it useful to talk about their experiences afterwards. For example, I really liked you when you done that activity. If there is something you would like to try, don't be afraid to suggest it. Now coming to the phases of the sensate focus. Sensate focus has three phases. First is non-genital phase, second is genital, then penetrative. We will get to know one by one. The aim of phase 1, which is non-genital sensate focus, is the first stage of sensate focus put the emphasis on sensuality, the simple enjoyment of physical touch rather than sexuality or pursuit to orgasm. So orgasm is not the goal in this phase. This phase focuses on touch and mutual exploration free from any concern that it will lead to sex. It's important, therefore, they abstain from any form of sexual activity during this stage. Even if one becomes very aroused, shouldn't touch one another's genitals or breasts, attempt to have intercourse or any other type of core sexual activity. Do not attempt to have or give an orgasm. Abstaining from sexual activity removes any pressure on the either partner to get an erection and become aroused or perform in any other way. It also helps break any established pattern of behavior that may have become routine and or boring. So this is an important part of sensate focus, that is non-genital sensate. The ground rules for non-genital sensate focus are: while it is preferably to be without clothes, one can wear inner wear or relaxed clothing if that feels more comfortable. Couple may find a book or video about massage will be useful if they want to learn different massage techniques. At this stage, avoid touching to the obvious erogenous zones. Only move from one state to next when you both feel they are ready. Sexual intercourse and orgasms are not permitted during this phase. The instructions for therapist can be: before the first session, decide who is going to go first, then take turn. During first session, concentrate on touching the parts of the body normally visible, for example, the hands, arms, feet, scalp and face. Include the back, neck, arms, buttock and legs also, but do not neglect the hands, feet and face. Finally, bring in the chest, stomach, shoulder and thighs, but avoid genitals, the breast, top of the legs and the groin area. Now come to the second phase of the sensate focus, which is genital phase. Now they can bring in touching of the breast and genital areas. Continue to pay attention to the parts of the body that were explored in the previous session as well as the new area that are incorporating. So one should incorporate the one should exercise the previous phase 1 exercise along with the phase 2, which is genital sensate focus. The main aim of these stages is to increase each person's pleasure and awareness of each other's responses to different type of stimulations. If one or both of they become aroused, this is fine, but it is not the aim of this exercise, the second phase. During genital stimulation, it is often useful to use a water-based lubricant. Sexual intercourse and penetration is not permitted during this phase also. The instructions can be: first, incorporate touching of breast and nipples. Remember, men have nipples too. Next, include the area around the genitals. Then introduce touching of the genitals. After a while, one may also want to incorporate manual touching, like kissing. One may want to try the teasing technique, manually stimulate the other person's genitals, and take a rest for a few minutes and then begin again. If orgasm occurs as the stage or later stages, this is fine, but that is not the aim of this process. Now come to the third phase, which is penetrative sensate focus. Now they can begin to include penetration. Continue to pay attention to the other parts of body that one has explored in the previous sessions. The female should be in control of the depth and the amount of time spent on it. While orgasm and intercourse is permitted in this phase, this is not the goal. The aim remains to enjoy the growing intimacy between the couple. Initially, try this with little or no thrusting. Feel the sensation of containment. Try in different position. Later, they can incorporate more thrusting in this phase. So the conclusion is, sensate focus is about to touch, about to learn about the touch, and touch is most primal sensation and need. By the time we are young adults, touch is often paired with the sexuality and expectation about the sexual touch abound. But this touch sensate really present throughout the life of an individual since the childhood. People need to relearn the importance of touching for its own sake, which can be said as touching mindfully in sexual activity. Re-experiencing the sensation of touch without the pleasure to like it or to be aroused by it or to simultaneously arouse the partner helps create a connection to oneself and or to the partner. When the conscious mind gets out of the way of the body may respond on its own, building up a symmetric charge. Now come to the start and stop squeeze technique. The stop squeeze technique is one of several ways one can delay orgasm and prolong uh, masturbation or partnered sex. It may also benefit people with experiencing premature ejaculation. Now, how to use stop squeeze technique? The stop squeeze technique is a form of ejaculatory control. It allows you to near the point of climax and then back off suddenly by holding the tip of the penis and stopping the further stimulation until the sensation subsides for the orgasm or climax. One can repeat the stop squeeze several times to regain the timing and gaining the experiences in the orgasm. Other than start stop, one can prolong foreplay, which also helps in alleviating pressure and expectations by foregoing intercourse for a longer period. Instead, focus on other types of sexual play such as massage, intimate touching, and kissing. If you are trying to delay your orgasm but not your partners, you might also try manual stimulations. This way, you may be able to delay your climax until they are ready In the moment strategy, one can masturbate before the intercourse. One may be able to delay ejaculation during intercourse by masturbating an hour or two earlier. One may not be able to anticipate sex beforehand in the every case, but when you can, this strategy might be helpful. Now, Kegel exercise. This technique was developed by Arnold Kegel in 1940. It was initially used for pregnant women whose muscles around the hips becomes weak after parturition, but later it was tried for sex problems in the men, which proved somewhat effective. But the controversies are there. Kegel exercise helpful in male sex problems. The main purpose of this exercise is to strengthen the muscle around the hip, which are called pubococcygous muscles. The benefit of Kegel exercise is it increases blood flow in the penis, which make the hard erection last longer, and it also beneficial in premature ejaculation. Due to increased blood flow to the penis, it increases the turgidity, it controls orgasm, ejaculation, and increases the duration of intercourse. The other benefits of this exercise are after getting used to it, there is little need for urination at midnight, help in keeping the prostate gland healthy, help prevent rectal prolapse also. Now, how to do the exercise? This exercise is simple exercise. It can be done easily anywhere without others even noticing that you are doing it. But it takes dedication to master this exercise, and after practicing for a few weeks, one can become proficient. So the question is how to identify pubococcygous muscle. Contract your the pubococcygous muscles are muscles which are around the pelvis, and it can be it can be recognized by the mechanism when you try to hold urination in between, then you have to contract these muscles. So one can find the pubococcygous muscles by this exercise. So contract your pubococcygous muscles in normal situation. Hold the Kegel contraction. After starting the contraction, hold it for as long as possible. Relieve the contraction and repeat. It may take time for some individuals to learn, but in 4 to 6 weeks you will feel the improvement. The special thing about Kegel exercise is that one can do this anywhere. Initially do up to 50 contractions a day and gradually incorporate it into your daily routine. During sexual activity, one can also exercise this. One can hold Kegel contraction for 10 seconds. Use it during sex to increase the time to ejaculation. During sex, when you feel that ejaculation is about to happen, immediately do the Kegel contractions and hold for 10 seconds. It takes effort, patience, and practice to learn it and adjust to it over time, but it is beneficial for the result, so keep practicing it. In the last, in non-pharmacological management, uh, one has to understand the normalcy. There are lots of misconceptions and myths regarding the sexual activity and performance in the usually in the younger population. So they feel anxious. So normalcy should be taught to them. The misconceptions and myths should be busted by explaining the reality. So their anxiety should go down, and if medications are required to lower down the anxiety, one can use the drugs also like propranolol and all. We also already had that lecture on pharmacology in the previous session, so one can go to that lecture and learn about it.
Okay, so welcome everybody. I'm Dr. Swaleha Mujawar, Assistant Professor in Department of Psychiatry, and today our topic for discussion is psychosexual cycle-based psychiatric disorders. So psychiatric disorders which occur during each and every phase of the psychosexual cycle. So, looking at the outline of today's lecture, I'll be taking a little bit of introduction, definitions, and then the male sexual dysfunctions and the female sexual dysfunctions. Okay. So, you'll be able to determine the relevant parts of history and physical examination in a male with sexual dysfunction, because we'll be giving you cases also, and you'll be seeing and presenting cases in the clinics. This will help you understand, and it will help you to know also what to ask in history, what to check in physical examination, and some incidence, epidemiology and pathophysiology of female sexual dysfunction. So yes, especially in India, we very rarely get female sexual dysfunction. So if we have a case, we'll definitely show it to you. But female sexual dysfunction is very, very rarely seen, even though it is very common. But coming to a doctor or coming to a psychiatrist is very difficult for them. So we rarely do see them, but you have to have an idea what they are in case that rare case actually comes to you. So introduction, uh, whenever we look at sexual dysfunctions or sexual behavior, you have to always keep an open mind. It is very diverse. It is determined by a complex interaction of factors. So it's not just hormones, or it's not just relationship. It's actually a combination of a lot of factors. So it depends upon the relationship with between the partners, between other people also, the life circumstances. Culture plays a very big role in sexual behavior. Then personality traits, the biological makeup. So this is where your endocrine system will come into being. Then general sense of self, the perception of being a man or woman. It also reflects the developmental experiences with sex throughout the life cycle. So starting say or bachpan say, when you'll see the history taking pro forma, the sexual history taking pro forma, we do ask about their first sexual experiences or early sexual experiences, because these also do play a role in developing the sexual behavior. So overall, broadly, if we have to classify sexual disorders, we will classify them into gender identity disorder, sexual dysfunction, and paraphilia. And these are again big topics. So gender identity disorder will cover in another lecture, paraphilias another lecture. For today, we are going to just focus on sexual dysfunctions. So sexual dysfunctions are divided into two, male and female. So in men, what are the sexual dysfunction scenes? Hypoactive sexual disorder, then sexual aversion, then male erectile dysfunction, which is the most commonly seen in our OPDs, then inhibited orgasm or premature ejaculation. Sometimes pain can occur, so dyspareunia. In female, the most common is the hypoactive sexual desire. They can have sexual aversion also, sexual arousal disorders, inhibited orgasm, dyspareunia, and vaginismus. So out of all these, men mostly present with erectile dysfunction and premature ejaculation. So these are the two main categories that we'll be studying in detail, and female present mostly with hypoactive sexual disorder. So male sexual dysfunctions, we have divided into these four categories: hypoactive sexual disorder, or they can just have an aversion. So there is zero sexual desire, then erectile dysfunction, and in orgasm, either they can have inhibited orgasm or premature. So it is occurring very late or it is occurring very early. So this is the male sexual response cycle. So whenever any male is presented with a sexual stimulus or the sexual process, it goes through these four cycles. So it starts with desire, then it goes to arousal, then arousal goes to plateau. So you can see here the plateau is there, and then there's orgasm, and after orgasm there's resolution. One thing to remember is the resolution, especially in males, is refractory. So if a sexual stimulus is presented during the resolution phase, then it is very unlikely that the male will be aroused again, because the patient is in a refractory period. And you have to know all these things, because a lot of times patients don't even have an idea about the sexual cycle, or what is normal, what is abnormal. A lot of times they don't know about refractory period. So you should know this so that you can psychoeducate the patient. Sometimes the refractory period can be small also in some males, so the resolution can be short and then they can be aroused again, but it depends from patient to patient or from person to person. So in some males, the refractory period can be 15 minutes. In some males, it can be 24 hours or 48 hours also. So all of it is normal. Nothing is abnormal. It depends just from person to person. So again, this is what I was trying to show. So in green is the normal response cycle, but some people can have something which is shown in yellow also, that is also normal. And the red part or the pink part, that is also normal. So all these things are normal. And whenever we have to describe any sexual dysfunction, we describe according to these categories or these phases of the sexual cycle. So if the patient has no desire, so the patient can have male hypoactive sexual desire or aversion. In aversion, there is definitely zero desire, and like they're quite afraid of having sex. In arousal, again, arousal disorder, plateau does not have any disorders. In orgasm, we usually have your premature or delayed ejaculation. So let's go to premature ejaculation first. So by definition, it is when ejaculation occurs sooner than desired, and there is a loss of control over ejaculation, and it should definitely cause distress to one or both the partners. So again, like we've told you, there's no set hard and fast rule. So if the patient feels that it is occurring sooner, patient is not having control, and there is distress. If there is no distress, if both the partners are satisfied, then it is not a disorder also. It is quite normal. But if there is distress in either of the partners, then we call it as a disorder and premature ejaculation. So what is too soon? Again, a lot of arguments were done, but what has been accepted or decided now is less than 60 seconds is premature ejaculation. Most agree that less than 120 seconds is also. So we usually ask the patient history mein, whenever patient comes and says that he is ejaculating very fast or sooner than normal, what you have to ask is what is the time, especially the intravaginal ejaculatory time. So if it is less than a minute or less than 2 minutes, then it's a disorder, but it is again dependent upon culture, dependent upon expectations. In epidemiology, it is the most common form of sexual dysfunction, and prevalence rates can vary anything from 4 to 39. Some studies have found 21 to 31, but in general, you can just take it approximately 30%. And these rates are not affected by age, marital status, race, country. So whatever findings are there, they are common throughout all different forms. Exact etiology is not known, but like most psychiatric illnesses, it's a combination of physiological and psychological factors. So primary premature ejaculation, by primary, we mean that the patient has always had premature ejaculation. That is, from the beginning, whenever he has sex, he has premature ejaculation. Acquired means ejaculation time was normal for probably a few years and then he developed. So if it is primary, it might be due to some endocrinological causes or some physiological causes. Secondary or acquired is mostly due to psychological causes, like again stress or some fights or some problems between the partners. So what do you ask in history? Very important to ask is the age at onset, because this will help in determining if it is primary, secondary. Then frequency of premature ejaculation. So whenever the patient has sex, does he have it every time? So is it consistent or is it intermittent? Like sometimes it is normal, sometimes it is abnormal. Circumstances are very, very important, especially if your trying to determine the psychological causes, then the circumstances are important, that after a fight, does it happen every time that there is a fight or some stress and then it is happening? So always ask the circumstances, the estimated time, like approximately how much time does he last, then any other sexual disorders like erectile dysfunction, then how has it affected the relationship, how has it impacted the sense of well-being, so everyday life or everyday mood, how has it been affected by this problem. So all these questions you are supposed to ask in your history. Physical tests or physical examination, not very useful. It's mostly due to psychological causes. So sometimes neurological conditions or some prostatitis can give rise to this. So that depends upon patient to patient. So if a patient has some neurological symptoms or there is increased urgency of micturition or other problems you can see, then it might be that. But there is no lab test to confirm the diagnosis of premature ejaculation. Like you have a malaria test or dengue test, so there's no test for this. And mostly, like I've told you, it's psychological, so we can do psychological tests to assess for anxiety disorder and other psychological problems. Treatment is usually treating the underlying cause. If there's a urinary tract infection, prostatitis, again, give antibiotics, treat the cause. Then we have from our side, from psychiatry side, we have two options: pharmacological interventions and behavioral interventions. Now in erectile dysfunction, and the treatment will be covering in another lecture, okay? So because treatment is a big part, so that is the last lecture. So just in treatment, remember pharmacological and behavioral. The detailed treatment part is another lecture again. Now coming to erectile dysfunction. So by definition, it is the consistent or recurrent inability of a man to attain and or maintain an erection sufficient for sexual performance. Okay, so basically the sexual performance should be affected in this. Prevalence 5 to 35% have moderate to severe erectile dysfunctions, and another study in the US found 16 to 22%. And in this study, 8% of the men in their 20s reported erectile dysfunction. So it is a age dependent disorder. Rate also depends upon the definition, like how is it defined. And we expect the rates will increase as the awareness of the condition also increases, because there are a lot of myths and misconceptions. Sexual education is not as prevalent, but the rates are probably more than what we have found. Now, what causes erectile dysfunction? So overall, it's a neurovascular problem. And again, the sexual response cycle is another lecture. So in that lecture, you will be going into details, but just an overview. What happens is, whenever there is sexual stimulation, parasympathetic nervous system is activated. I'm sure you must have read this in probably anatomy physiology also. Then there is an increased production of cyclic GMP. The smooth muscles relax because there is increase in cyclic GMP, and because of the smooth muscle relaxation, blood flow increases into the penis, and filling of the penis, then it causes engorgement. There is compression of outflow of blood via the veins, and this is what is happening during a normal erection. And all this is a neurovascular, so parasympathetic nervous system, cyclic GMP, all these things you remember, because this will help in our treatment also. So physical causes can be vascular. As we have seen, the blood flow is supposed to increase. So due to any vascular cause, if the blood flow is not able to reach properly, then it can cause erectile dysfunction. Cavernosal problems, neurological problems, because parasympathetic nervous system is involved. So any nerve damage can also cause erectile dysfunction. And then obviously hormonal causes. So if there is low serum testosterone, endocrinological problems are going on, again erectile dysfunction can occur. In psychological factors, again stress, anxiety, problems in relationship with the partner, all these things can also lead to erectile dysfunction. So what do you ask in these patients? In these patients, especially in sexual history, you are again supposed to ask onset of symptoms, duration of symptoms, circumstances when erectile dysfunction occurs. So problems with having an erection is one, and problem with maintaining erection. So both these questions you are supposed to ask. Also ask about the libido and any comorbid, again, sexual problems like premature ejaculation. Medical history, very, very, very important. So any comorbidities like cardiovascular illness, diabetes, depression, alcoholism. Is the patient a smoker? Smoking 100% causes erectile dysfunction. So if the patient is a smoker, that might be a cause. Any pelvic surgery, radiation or trauma which might cause neurological damage. Any other neurological disease, any endocrine problem, any recreational or prescribed medication use, a lot of medications and a lot of drugs can also cause erectile dysfunctions. So what are the medicines which are known to cause? One is antihypertensives, so thiazide diuretics and beta blockers. These are very common to cause erectile dysfunction. A lot of antidepressants like SSRIs also do cause erectile dysfunction, and then hormones obviously will cause these problems. So you're supposed to take blood pressure in most patients. Testicular examination should be done, examination of penis, vascular and neurological if it is indicated. So if there is something in the history, then you do it. In lab, we send serum testosterone, especially if there is a comorbid decrease in libido, then definitely serum testosterone should be sent. Older patients, send a lipid profile because lipids can deposit on the blood vessels and hamper the blood flow. Fasting glucose should be sent. In some patient, prostate specific antigen and prolactin also, but these are rarely sent. Mostly we send for serum testosterone, lipids and sugars. So treatment involves identifying and treating the organic causes. So any vascular or neurological cause, you treat that. Counsel and educate the patient and the partner. If you feel there are some psychological problems, then you identify and treat them. We have a lot of medications, we have a lot of devices, and we have surgery also. So all these three things, medication, devices and surgery, will be covering in the treatment part of the lecture. So we are finished with half of our lecture, that is the male sexual dysfunction. Now we'll be looking at the female sexual dysfunction. So like I've told you, these cases are very rarely there. So again, we'll just go through them very quickly. So the phases are the same in females also. So we have desire and arousal, which is the excitement phase here. So these are similar in most cases. Then there's plateau, then there's orgasm. The only difference between males and females is that there is no refractory period in females. You can't see any refractory period here. So the patient, if the patient has had an orgasm, patient can again have excitement like you've seen here. So excitement phase can occur anytime. Plateau can also go on for a long without any orgasm. So these are all normal. Whatever 1, 2 and 3 you are seeing, all three are normal. And this is how a usual female sexual response cycle occurs. And we'll be looking at the problems also according to these phases. So we have, if the excitement phase is a problem, we have hypoactive sexual desire or sexual aversion. We have problems in orgasm, especially in females. Sexual pain disorders are very common. So patient can have dyspareunia, vaginismus also, and other pain related disorders also. So what is hypoactive sexual desire disorder? It is a persistent or recurrent deficiency or absence of sexual fantasies or thoughts or desire for a receptivity for a sexual activity. So basically the patient has no desires or no sexual fantasies at all, and it causes personal distress in the patient also. And usually it can be either due to menopause, surgical or medical menopause. Sometimes it can be due to some endocrinological disorders also. Sexual aversion disorder is a phobic aversion to sexual contact. So here also there is personal distress, but there is absolutely zero desire and a lot of phobia towards sexual contact. And it usually results from childhood trauma, either physical or sexual abuse. So this actually one case we had seen, like one female had come and she had sexual aversion disorder, and there was some history of trauma also in her. Then there is sexual arousal disorder. So persistent or recurrent inability to attain or maintain a sufficient sexual excitement. Again, it causes distress, can be due to medical causes, may be expressed as a lack of subjective excitement, like the patient feels that there is no excitement, or there can be lack of genital lubrication or swelling also. Then there is orgasmic disorder. So a persistent or recurrent difficulty, delay or absence of attaining orgasm after a sexual stimulation. Again, it should cause personal distress. Just like premature ejaculation, it can be primary, that is never attained orgasm. So again, there might be some emotional trauma, sexual abuse in these patients. It can be secondary, again due to some pelvic surgery, hormonal deficiencies and traumas. Sexual pain disorders are very common but mostly seen in gynae OPD. So they won't directly come to a psychiatrist, but they usually have a recurrent or persistent genital pain with sexual intercourse. And we have to first rule out vestibulitis, vaginal atrophy, vaginal infection. So again, it is usually done in liaison with the obs gynae department. After ruling out all these things, even if the patient has this paranoia, then it is psychological. Vagismus is a spasm. So there is recurrent or persistent involuntary spasm of the musculature of the outer third of vagina, and this interferes with vaginal penetration. So it can be either a conditioned response to a painful penetration. So again, there is some psychological or emotional trauma, but whenever penetration is occurring, there is an involuntary spasm. So all the muscles are going into spasm, and this is causing pain in the patient. Other sexual pain disorders can be caused due to herpes simplex infection, again vestibulitis, genital mutilation, trauma, endometriosis, interstitial cystitis. So all these things you're supposed to rule out in a patient with sexual pain. And interstitial cystitis especially is very, very common, and it is divided into two: entry and deep dyspareunia. Now, in etiology, just like in males, in females also, it can be vasculogenic, neurogenic, hormonal, musculogenic, and psychological. So, in vasculogenic, again, we have hypertension, hypercholesteremia, smoking, heart disease. So, very similar to male causes. It is associated with erectile dysfunction in male and sexual dysfunction in females. Because in females also there is decreased vaginal and clitoral blood flow, either due to atherosclerosis or any other causes. And it can lead to symptoms of vaginal dryness and pain. There can be alteration in circulating estrogen levels also. So decrease in estrogen due to any other cause, trauma, pelvic fracture, this can also cause. Neurological, again, spinal cord injury, diabetes, all these other causes. Hormonal causes, anything from your hypothalamic pituitary axis to your ovaries. If anything is abnormal, then sexual dysfunction can occur. Musculogenic, so some muscles are also involved. So levator ani muscles, perineal muscles, all these, if they go into spasm or hypertonicity, it can cause vagismus or dyspareunia. If there is hypotonicity or decrease in tone on these muscles, then again there is urinary incontinence and orgasm problems. Psychological, it can be emotional or relationship problems due to either self-esteem problems, body image problems, and medications like SSRIs. So SSRIs were causing sexual dysfunctions in male also and in females also. So remember this, always ask patient about what medications he or she is taking. Now, clinical evaluation, what are you supposed to do? First, a medical evaluation, rule out all causes which we have seen, neurological, vascular. If all these are normal, then you go to psychological assessment, ask for stressors, relationship with the partner again. So a full history, physical examination, pelvic examination. In females, you have to send all these tests. FSH, LH, prolactin, free testosterone, serum beta HCG, estradiol, all these tests should be done. If you feel that there is some blood flow problem, you can do a Doppler study, check for vaginal pH, genital sensation can also be checked. And if there are some psychological trauma or you feel that the patient has some psychological issues, you can add these tests. So there is a brief index of sexual function, BISF, and inventory of female sexual functions. So it's a list of questions that you're supposed to ask, and it tells you the score, and according to the score, then we diagnose it. So in conclusion, it is a very interesting area, applicable to all physicians. So it's not necessary that you should be a psychiatrist to know and treat all these illnesses. These patients can come to you in your OPD irrespective of your specialty. And all the physicians, as physicians, we need to learn through research and patient care about one, the epidemiology, which we have covered, how to make a diagnosis, the pathophysiology, and the treatment. So all of you are expected to know at least these four things, uh, irrespective of whether you take psychiatry or you do psychiatry or not. This is minimum what is expected. Okay, so thank you so much for listening. So welcome everybody. Today we are going to discuss the pharmacological interventions, the options that we have to treat sexual dysfunctions. So I'm Dr. Swaleha Mujawar. I'm the assistant professor at Department of Psychiatry. And first we'll see the treatment of male sexual dysfunctions, what medicines we have or what medical options we have. So for pharmacological interventions for premature ejaculations, we have options for topical anesthetics, tricyclic antidepressants, or other antidepressants like SSRIs, and phosphodiesterase 5 inhibitors. So we'll see each and every one of them in detail. So topical anesthetics, they decrease the sensitivity of penis and hence they increase the time that the patient can last. So that is basically the mechanism of action or the mode of action, quite simple, no doubt in that. There's lidocaine and prelocaine cream which is usually used. So how to use it? You explain to the patient that you apply to the penis 20 to 30 minutes prior to the intercourse, and after the intercourse he's supposed to wash it off. So this is how it is used. The potential problems can be loss of pleasurable sensation for both the male and female, because we are using anesthetics, so the anesthetic will be absorbed by the female also, so both of them will not have any sensations. So there is a loss of pleasurable sensation. Then there can be contact skin reaction or allergies also. So before using, it is better to just give a test dose to check if the patient is allergic or not. So this was about topical anesthetics. Then coming to the antidepressants. So tricyclic antidepressants, uh, how do they act? Their mechanism of action is they are presumed to act via the neurotransmitters involved to inhibit ejaculation. So we are acting at the central level now, or at the nervous level now. So whatever neurotransmitters are involved, this is what is affecting them. The most commonly used TCA is clomipramine. It is used either as a need basis, like just before intercourse. Again, patient can take half an hour or 1 hour before the intercourse, or the patient can take it continuously also, because it's a antidepressant, so it might decrease the anxiety or the stress also. So it has both actions. Potential side effects which are seen with TCAs, like anticholinergic side effects or sedation, orthostatic hypotension. So these side effects can occur if we use TCAs, and it is not FDA approved, or it's not standardized. These are just anecdotal evidences, but they do work, so they are used. But now we have uh, the comparison for daily versus as needed clomipramine. So a study was done which compared on demand clomipramine use in men with premature ejaculations, and three factors predicted the likely success of on demand use or SOS use. So men with IL greater than 60 seconds, so who were able to last more than 60 seconds, who had a higher self-reported sexual satisfaction, and men who ejaculated 2 or more times per week. So if the patient profile fits these criteria, then using clomipramine as a SOS or on demand use is better. So patients who are able to last more than 60 seconds, higher sexual satisfaction, and 2 or more times a week was the frequency. So this is our clomipramine or TCAs. Now we have other options, and we have better antidepressants with fewer side effects. So they are also acting centrally through serotonin receptors, and they inhibit ejaculation. So mechanism of action is similar to TCAs. They are acting on the neurotransmitters which inhibit ejaculation. The most common SSRI which we use is paroxetine. In fact, the case that a few of you had seen, we had given like Dr. Divijit, he had given paroxetine. So how can we use it? Again, we can use it SOS or on demand, or on a continuous basis also, or sometimes a combination of both. Potential side effects are the usual side effects which are seen with SSRI. GI distress is very, very common. Paroxetine again can be sedating in some patients. So side effects are found, and again the doses and regimes are not standardized. So a lot of studies have not been done. It's not FDA approved. But some of the guidelines which I could find was that you can give fluoxetine as low as 50 mg to 20 mg per day. So this is a very low dose fluoxetine which we are giving. Then we can give paroxetine 10 to 40 mg per day, or 20 mg 3 to 4 hours before intercourse. Sertraline can also be given 25 to 200 mg per day, or 50 mg just before intercourse. Clomipramine again 25 to 50 mg per day, or 25 mg if you're giving as SOS basis. So these are the antidepressants which are usually used. And like I've said before, we have the uh, like it has two mechanisms of action. One is it is inhibiting ejaculation, but also it decreases anxiety. So if the patient has premature ejaculation due to performance anxiety, these drugs will also work. Now we have phosphodiesterase 5 inhibitors. So what is their mechanism of action, or how do they work? Again, having higher cyclic GMP levels might prolong the nitrous oxide effect by delaying ejaculatory emission. So hopefully you know the physiology behind uh, the ejaculation and the how nitrous oxide, how cyclic GMP are working. So by increasing the cyclic GMP levels and increasing the nitrous oxide level, sometimes ejaculation can be delayed. It can prolong erections also, so it may reduce the performance anxiety. So if a patient has better erections, then he might be again able to last longer, and the incidence of premature ejaculation can decrease. The commonly used phosphodiesterase inhibitor is sildenafil, which is commonly known as Viagra. So it is used over the counter also by a lot of patients, but it should be used only by prescription. It is used by 25 to 100 mg 1 hour before sex. Potential problems are there, side effects are there. You should not give if the patient has myocardial infarction or cardiac problems. A lot of antihypertensive medications also interfere with this. So be very careful about the side effects and drug interactions. And whatever studies were done, limited benefits were there. So the studies could not found a lot of uh, benefit from using phosphodiesterase inhibitors, but you can use it according to the patient. Now, when we compare oral medications, a lot of studies proving the efficacy was found using SSRIs and TCAs. And again, in SSRIs, paroxetine was working the best. Sertraline and fluoxetine was the second best. And although more efficacious in some studies, almost twice as many adverse effects were also reported with clomipramine. So yes, clomipramine was more effective, but the side effects were also more with clomipramine. So that's why we don't use clomipramine as much as we use SSRIs. The evidence for sildenafil is weakest, particularly without concurrent erectile dysfunction. So if the patient has erectile dysfunction and you are giving sildenafil for it anyways, so then it might help with premature ejaculation, but in itself, it does not have a very strong evidence. So whenever you see a patient, always consider comorbidities. So if the patient has atopic dermatitis, you can't use local anesthetics. Or if the patient has comorbid anxiety, using SSRIs or antidepressants might work well. Also know all the side effects of the medications so that you can again fit it according to the patient profile. TCAs being sedating, you can't give it in a working patient because next day patient might have sedation. So always keep side effects in your mind. Then expense also. A lot of times these medications are expensive. Like TCAs are very cheap, but again they have side effects. But if the patient is not able to afford SSRIs or expensive medications, then TCAs might also work. So just choose your options according to the patient. And ultimately, it's a shared decision between the patient and the provider. Keeping all these things in mind, then you decide the best treatment option. Now, coming to erectile dysfunction. So, treatment of erectile dysfunction, first and foremost, identify and treat the organic comorbidities and other risk factors. So, if there is an organic cause for erectile dysfunction, treating the cause will automatically treat the erectile dysfunction also. Counsel and educate the patient and the partner. Sometimes counseling can also help, or sex education can also help in cases of erectile dysfunction. Identify and treat any psychosexual dysfunctions. So again, if there is some relationship problem between the partners, or the patient is going through some problems, then treating those might also help in treatment of erectile dysfunction. Then we have a lot of medications, we have a lot of devices available. Last resort, sometimes surgery can also be done. So treatment starts with your lifestyle modifications. So weight loss helps a lot. Increase exercise, stop smoking, because smoking affects the blood vessels, so it will definitely affect the penile blood vessels also and cause erectile dysfunction. And first and foremost, these should be done. After that, let's look at the study. So a study was done and it showed an improvement in erectile dysfunction of ex-smokers. So the age groups were 30 to 39, 40 to 49 and 50 to 60. And the erectile dysfunction was also graded as mild, moderate, severe. So looking at the total age group, if the age group was young, then quitting smoking helped almost 38% of patients. As the age increased, 40 to 49, 27% showed improvement, and above 58%. So quitting smoking as soon as possible will always be better. So this is what you are supposed to tell the patients also. Now, before we had medications, we had a few older treatments also. Older treatments were intracavernosal injections, vacuum constriction devices, intraurethral suppositories, inflatable prosthesis, and vascular surgeries. So this was the intracavernosal injections. So injections were given in the penis. Usually these were again anesthetic injections, and intraurethral pellets were also used. Sometimes vacuum constricting devices in the lower half of the diagram you can see, and sometimes inflatable prostheses were also used. So these like injections were painful, the pellets were painful, constrictive devices or prosthesis were also very uncomfortable to the patients, but at those times there was no other option, so this was what was used. But now, especially with the advent of sildenafil, these older devices are not used. Like Viagra brought a lot of changes in especially erectile dysfunction. So we have phosphodiesterase 5 inhibitors, we have sildenafil, tadalafil, and vardenafil, and sometimes euhimbine can also be used. So phosphodiesterase inhibitors, all of them are similar in effectiveness. So they are all equally effective. 75% of men on medications have satisfactory erection to complete intercourse. So 75% is a very good result. But no large head-to-head trials were used to compare the three medications, and some patients prefer one over the other. So again, it depends on the patient preference also. So when we compare sildenafil, tadalafil, and vardenafil, you can see the effectiveness or the efficacy is almost the same. The success rate, the improvement, the withdrawals, all of them are very similar. And let us look at the standard dose. So sildenafil, like we have seen before, it is given 50 to 100 mg. Tadalafil comes in 10 and 20 mg. And again, vardenafil is also 10 and 20 mg. It is usually given 1 to 2 hours before intercourse. Tadalafil, you will see, has a duration of action of 36 hours. So it lasts more than 2 days. So because of this, it is commonly called as a weekend pill. So if you take this pill over the weekend, the mechanism of action lasts throughout the whole weekend. Comparatively, sildenafil and vardenafil, they have a duration of action of just 4 to 5 hours. So it has a very less action. So it is used once, and then after the intercourse, if 4 to 5 hours have gone, the patient might need to take another pill again. Cost wise, they cost quite the same. So what are the instructions that you tell before using phosphodiesterase uh, inhibitors? Because you're using this on SOS basis, you're using it before intercourse only. So what are the things that you say? First, tell the patient that it still requires sexual stimulation to have an erection. So it's not that the patient will take the pill and immediately have an erection. There still has to be some sort of sexual stimulation from the partner or from the patient to have an erection, and its absorption may be reduced by foods, especially fatty foods. So if the patient is going to take a meal just before taking the medication, try to avoid fatty foods. Maximal efficacy comes within an hour, and if the patient is using tadalafil, 2 hours. So that's why we tell the patient to take it 1 to 2 hours before intercourse. First few doses may not be successful, and if the patient does not have an erection in 1 or 2 doses, tell them at least try it 6 to 8 times before giving up. Side effects which are expected is headache, because it is causing vasodilation. Indigestion, GI side effects can occur. Again, vasodilation might lead to flushing, nasal congestion. A very interesting side effect which is seen is blue hue to the vision. So sometimes patients start seeing blue after taking these medications. So these are the side effects. Contraindications: never, never, never use it with nitrates. Nitrates are given in myocardial infarction and cardiac patients. So if the patient is on nitrates, it's a contraindication. You can't give phosphodiesterase inhibitors. Do not use if the patient has a severe cardiovascular disease. Uh, Vardenafil, again, use it very carefully if the patient has prolonged QT. So getting an ECG done before starting these medications is your best treatment. Care if the patient is on alpha blocking agents. Usually alpha blocking agents are given if the patient is a known case of hypertension, or if the patient is hypertensive. So if you give both of these drugs together, it can cause significant hypotension. So ask all these things in history before you start these medications. So ask for any history of hypertension, any history of cardiac diseases, or any cardiovascular diseases. So follow-up is always recommended in all the patients to see the effectiveness of the drugs, to check for any side effects or any significant change in health status, including any new medication that the patient is taking. So always have a good follow-up with these patients. If the patient is coming to you on follow-up and says that the treatment has failed, what can be the cause? Either food or drug interaction. So ask the patient, do you have fatty foods before taking these, or do you have other? Timing also, timing should be 1 to 2 hours before intercourse. If the patient is taking adequate dose or not, if there is lack of sexual stimulation, then you have to educate the patient that there should be proper sexual stimulation also. Heavy alcohol use is avoided, or patient should be told if they can stop alcohol altogether, that is the best. And any relationship problems also should be countered. Now yohimbine. So yohimbine is derived from the bark of a yohimbine tree in Central Africa, and it was traditionally used to treat all forms of impotence. Uh, so now it has come into clinical work also. So it is believed to work through the central nervous system. It is an alpha 2 receptor blocker, and a lot of studies were done, and meta-analysis showed that it was superior to placebo. It's a relatively safe medication. The cost is also very, very less. But again, a lot of approvals have not been there. So American Urology Society also does not recommend its use. Now coming to female sexual dysfunctions. So what are the options available to us? We have sildenafil, we have DHEA, PG1 inhibitors, apomorphine, L-arginine, yohimbine again, and vacuum therapy devices. So let's look at first sildenafil. So 33 postmenopausal women in a study were studied, and patients who had heart diseases, uncontrolled psychiatric disorders, diabetes, alcohol, cardiovascular, or myocardial infarction or nitrate therapy, these were all included from the study. They were given sildenafil 50 mg 1 hour prior to the planned sexual activity, and then a questionnaire was applied. This questionnaire was a 9-item index of FSFI. FSFI is your female sexual functioning questionnaire. So what they found was 3 patients dropped out because of adverse effects. So clitoral hypersensitivity was found in 7 patients. A lot of patients had headache, dyspepsia, dizziness, which is a very common side effect of sildenafil. No differences in intercourse satisfaction and sexual desire was found after 3 months of therapy. And women on HRT or hormone replacement therapy had a overall increased score, even though it was not statistically significant, but an improvement in score was seen. But here the problem was that placebo was not used, and a lot of questions were raised, like would higher doses would have helped? What is the role of combination of therapy? Should topical therapy should have used? So this study was had a lot of pitfalls, and 50% of the women achieve orgasm regardless of the injury type. So in injuries, sildenafil works very well in these patients. Sildenafil was given to women, 19 women with injuries, pelvic injuries, and there was increase in arousal, increase in sexual stimulation, heart rate, and decrease in blood pressure was also seen. Now, female sexual dysfunction also with comorbid depression. So what do you do? In this, it was found that 50% of patients on SSRIs have some sexual dysfunction. So 10 women with depression on SSRI with sexual dysfunction were studied, and 50 mg of sildenafil was given to these patients. 9 out of 10 had reversal of anorgasmia or delayed orgasm, and most of this was seen with first dose of sildenafil. So again, if you have a patient with depression on SSRIs who come to you with sexual dysfunction, then sildenafil is a very good drug in this type of patient. After hysterectomy, will it work? So 35 patients, 35 women were evaluated who had undergone hysterectomy, and a pre and post treatment assessment was done. They were given a relatively higher dose. They were given 100 mg of sildenafil for 6 weeks, and they found an improvement in sensation, improvement in ability to reach orgasm, and a decrease in pain and discomfort. So again, if a patient has had hysterectomy, sildenafil 100 mg works. Coming to other medications, we have DHEA, which is dehydroepiandrosterone. So it is an adrenal gland hormone. It is a precursor to sex steroid, testosterone, and estrogen. It is given in daily doses. We have options of 50, 75, and 100. And a study was done again, which included women with sexual dysfunction for more than 6 months, and these women had low serum testosterone levels. So if these patients were given DHEA for 2 to 6 months, there was an increase in mean and free testosterone level and an improvement in sexual desire also. So what did we find with this study? That if a patient has sexual dysfunction and if a patient has low serum testosterone level, then giving DHEA will work. So you should know what type of patient, what medication you should give. We have topical medications also. So topical alprostadiol, it is it comes in 1% formulation. It is a 0.25 milliliter gel. So this is placed actually on the penis, allowed to dry, and then patient is asked to have vaginal intercourse. So in this, 36 healthy volunteer couples were divided into treatment and controls, and all men had erectile dysfunction. The results which were seen was there was no change in vital signs of either of the partners, but in females, some improvement was seen in the clitoral and vaginal sensations. So again, if the patient's partner also has erectile dysfunction or other problems, then using topical medications is helpful. It also comes in the form of pellets, especially useful in women having vaginismus. So it comes in the form of 1000 micrograms of pellets. These have to be inserted vaginally before intercourse, and the study had evaluated patients and seen that there was improvement in vaginal muscle spasm. So patients having vaginismus, these pellets do help. Intranasal apomorphine was also used. So apomorphine acts centrally to facilitate erectile response. 12 healthy women were studied, and they say that it was well tolerated, and efficacy studies are being done, and let's see, but this is also one treatment option. Then we have others, like, these are not medications as such. These are considered as food or vitamin, which are supplements. So along with other medications, you can give supplements. So supplements like ginkgo biloba, ginseng, L-arginine, calcium, iron, zinc, multivitamins. So all these things can also be given. So premenopausal, perimenopausal, and postmenopausal women were studied, and there was improvement in sexual desire, sensation, sexual satisfaction in perimenopausal women. In postmenopausal women, improvement was there in sexual satisfaction, and in premenopausal women also, there was improvement in desire and satisfaction. So yes, these therapies work, but they are used as adjuvant or add-on therapy. They are never used alone. Coming to L-arginine and yohimbine again, so 6 grams of arginine and 6 milligram of yohimbine is usually given. The study included 23 post-menopausal women, and physiological arousal was measured by vaginal impulse amplitude, and a subjective arousal was also measured using a questionnaire. So results which were found was, again, the response was better. The drug was reaching peak plasma at 40 minutes. So again, it is usually given 1 hour before intercourse or half an hour before intercourse. We have therapy devices also, just like we had for male sexual dysfunction. We have therapy devices for female sexual dysfunction also. So here the treatment was designed to increase the clitoral blood flow, to enhance the clitoral engorgement and improve the arousal. So 32 subjects were used, 20 were your cases, and 12 were your control. So, see, almost 90% of the patients who had sexual dysfunction said that there was improvement in sensation, improvement in lubrication. They were able to achieve orgasm also. There was increased sexual satisfaction also. So, yes, these therapy devices do work, but it's just that they are very uncomfortable to use, and they require a lot of instructions also to be used by the patients. No side effects were noted by the device because we are using these locally, so there are no systemic side effects. A study by the same author studied diabetic women also. So in diabetic women also, there was, you can see, almost 80 60% improvement in sensations, lubrication, orgasm, and satisfaction. So a lot of significant improvement was seen. So if the patient is diabetic and not able to take medications due to some interaction or side effect, then therapy devices do work in these patients. Okay, so welcome everybody. So in continuation with the psychosexual lecture series, today we are going to learn about paraphilias. So just a revision, yesterday we had gone into psychosexual disorders, but those disorders were according to the cycle. So if we want to divide sexual disorders into three parts, one will be yesterday's psychosexual disorders according to the cycle, then paraphilias and gender identity disorders. So today we are going to do paraphilias, and the next lecture will be on the third one, that is the gender identity and other issues. So let's get into paraphilias. So paraphilias are, yes, considered abnormal or a disorder, but just like anything in sexual disorders, what is considered as an unusual, abnormal behavior is very difficult to define. Like a lot of unconventional sexual behaviors do happen, but if it is between two consensual adults, there is no distress, no problem, then it might not be called as abnormal. So that is why defining abnormality is the most important thing, especially in psychiatry. Normal and abnormal have to be distinguished very, very clearly. So abnormal means those disorders or that behavior is rare, then it deviates from the cultural norms, so it is out of keeping with the cultural norms. Then it should cause discomfort either to the patient or to the partner. Then causes some inefficiency, so they're not satisfied or they're not able to have proper sexual intercourse. Some paraphilias are just bizarre, so that is also a criteria, and it cause harm to self or others. So these are the set criteria which help us in defining abnormal sexual behaviors. And in keeping with that, paraphilias are defined according to DSM-4. So DSM is a diagnostic and statistical manual. So that is used for diagnosing all mental illnesses. And in paraphilias, DSM-4 says that it is a mental disorder in which there is recurrent intense sexual urges or sexually arousing fantasies or behavior. Okay, so this is one criteria, that it should be recurrent, it should be intense, and there are sexual urges. What are these urges? We'll see in the next point. But this should be present at least for 6 months. So one or two episodes is not considered abnormal. It should be persistent, it should be recurrent, and this should be going on at least for 6 months. Now, these sexual urges or sexual arousal can involve either a non-human object, or it can involve suffering or humiliation of oneself or one's partner. We'll be seeing what these definitions are, but just go through the criteria once. And the third involves children or other non-consenting people, and the person has to act upon these urges. Just these urges are not enough, there should be some action, or if the patient is not acting on them, there should at least be distress by them. And like all psychiatric illnesses, there should be clinically significant difference or distress in social, occupational, and other impairments, uh, or other areas of life should also be impaired. So there should be some social disruption or some occupational disruption which was not there before, and which is being caused by these sexual urges. So, when we want to talk about paraphilias, we have included a few common ones. There are some other uncommon ones also, but we'll just see what usually is seen in our OPD. So, focus of sexuality is on something or someone other than a consenting adult. So this focus can be like we have seen a non-human object or children or involving some cause of distress. So we have fetishism, voyeurism and exhibitionism, transvestic fetishism. Then we have sadism and masochism. Then rape is also included here in some books and some articles. Then pedophilia and incest is the last. So, what is fetishism? Fetishism is basically sexual attraction to a non-living object. So, they get aroused or sexual arousal occurs due to some non-living object. So, it can be shoes or undergarments. And voyeurism and exhibitionism is like voyeurism is observing individuals in a state of undress without their knowledge. So these are called as peeping toms. And exhibitionism is the opposite. It involves exposing oneself to strangers. And both these have a thrill seeking component, or the patient gets a thrill or an arousal out of doing these things. So, first, let's see what all of these are, then we'll go into detail. So transvestic fetishism is sexual arousal is occurring by the act of cross dressing. So the patient cross dresses and then gets sexual arousal due to this. Spouses are often quite supportive in these cases. Sadism and masochism. So sadism, it involves sexual excitement by hurting others, and masochism involves sexual excitement when they are getting hurt. So it is the opposite of sadism. And a wide range of activities are involved in this. So it is a continuum, but mostly like whenever a hurt is involved, it can be sadism and masochism. And some people or some psychiatrists considered rapists as a subset of sadism, and they do meet the criteria for paraphilias also. Pedophilia is sexuality focused on children and can involve either or both sexes. And now, because of the awareness in child abuse, these cases are coming up, and it has a long-term impact on both men and women. So, treating this or focusing on this are very, very important, and it will help in bettering the society also. And what is seen is all these paraphilias are seen mostly in men. So there is a lot of speculation as to why only men have these tendencies, or probably something to do with testosterone, but the etiologies are there. Now coming to fetishism. So fetishism, we have seen that a patient has some attraction to a non-human object. Now this can be a mild preference, so it may or may not be there during the sexual activity. They can have strong preference also, but then they are able to have sexual intercourse without that object also. But if it becomes a necessity, that they need if they have fetishism for boots or shoes, so they need shoes during the sexual act, otherwise they can't have arousal. And sometimes it's a substitute for humans, so they don't need a partner or they don't need anything, they just need that object. So again, like shoes, so they just need that object for the sexual act to occur. So if it becomes a necessity, if it becomes a substitute for humans, then it is considered abnormal. So a mild preference or strong preference is normal. It's nothing to worry, or it's not even a paraphilia. But if it is a necessity, then it becomes abnormal. In fetishism, sexual arousal occurs either solely or predominantly with a non-living object, and this object is usually intimately associated with the human body. And the word fetish means magical. So the non-living object magically becomes phallic or sexual for that person. And this disorder, again, exclusively seen in males. Most disorders you will see is seen mostly in males. So the objects can be shoes, gloves, like any undergarments or stockings, and it is not diagnosed if the sexual object is wearing clothes of the opposite sex, because then it becomes a fetishic transvestism. And other, like if you're if masturbation is there or using a vibrator is there, again then it is not considered as a fetishism, because that is, again, we have considered it under normal. And fetishism is often associated with masturbation, but masturbation in itself is not abnormal. Oh yeah, बुला दूं क्या? Okay, fine, it is quite. भैया को बुलाओ. We don't want stings and bites here. Okay, so coming to sadism, here the patient who is doing the act is called a sadist. So, sadist is a person who is sexually aroused by physical or psychological humiliation, suffering. ला लो ठीक है. So here the patient is actually causing some humiliation, so some psychological harm, suffering or injury on the sexual partner. So the partner is the victim, and the person likes to inflict some pain, some psychological or physical pain on the victim. And again, mostly done by males, though it is not very essential, but mostly males are the ones who are sadists. And the methods used can range anything from tying, beating, burning, cutting, stabbing, and like we've seen before, so rape also comes. It can go as extreme as killing also. So yes, this is quite a worrisome paraphilia. Masochism is the reverse. So here the patient is sexually aroused by physical or psychological humiliation or suffering or injury inflicted on self by others. So they need someone, they need their partner to inflict pain on them, to humiliate them, and after they feel pain and humiliation, then they are sexually aroused. So this is what masochism is. And most often masochist is a female. Again, nothing hard and fast, but mostly it is a female who is a masochist. So methods used are the same as that we have seen in sadism, only there is a role reversal. And to be called as a disorder, it should be persistent and significant mode of sexual arousal. So the patient does not get arousal due to other techniques and needs just the pain to be present to go through a sexual activity. And sexual sadism and masochism are often seen in the same individual and are on a continuum. So they might have had somebody inflicting pain on them, and after that they feel that yes, they should also inflict pain on some other person to get sexually aroused. So the same person can have both these tendencies, and if that is there, then it is called as a sadomasochism. Especially this is there in ICD-10. Now, exhibitionism. So, exhibitionism is a persistent or recurrent significant method of sexual arousal by exposure of one's genitalia to an unsuspecting stranger. So, usually they will, again, mostly males, so they would like to show their genitalia to other people, and after showing this, they get sexual arousal. And it is usually followed by masturbation to achieve orgasm, exclusively seen in males. And unsuspecting stranger can be a female, a child or adult, so the victim can be anybody, but mostly it is seen in males and males alone. Then voyeurism. So voyeurism is the opposite of exhibitionism. Here, the patient needs to see somebody who is either naked or undressing or doing some sexual activity. So by watching other people, they get sexual arousal. So this is known as voyeurism, and because of this, they are called as peeping toms. And again, it is followed by masturbation to achieve orgasm, and usually the people who are being observed, they don't know or they are not aware. In exhibitionism, the person is also aware to whom they are exposing, but here the people do not know that they're being watched or something. So that is what leads to sexual arousal in this in these cases, or in voyeuristic people. And again, here watching pornography is not included. Whatever the patient is seeing, or patient is watching, somebody is watching in real life. So they have excluded pornography out of this. Now coming to the next one, next is fracturism. So here there is a persistent or recurrent involvement in the act of touching and rubbing against an unsuspecting person. So these people who are suffering from this paraphilia, they need to touch or rub against some non-consenting person to get a sexual arousal. And because this is possible very easily in crowded places, like buses or crowded markets, so usually what they'll do is they'll prefer traveling by buses, or they'll prefer places which are very crowded, so that they can go and just unsuspectingly or unconsentingly touch these people. And if it occurs in a crowded place, the victim also does not protest, because they just feel that it's part of a crowd, so they cannot suspect that some act is getting carried out here. More commonly seen in young males, adolescent males. So this is what is fraudurism. Now, pedophilia. So yes, this has been gaining more and more awareness currently. So you should know the definition, because there are a lot of medical legal implications in the cases of pedophilia. So when is pedophilia defined, or how is it defined? Again, persistent and recurrent involvement of an adult. So the definition of adult is anybody more than 16 years of age. Usually adults we define as more than 18 years. But for pedophilia, we have lowered it to 16 years or 5 years older than the child. So if the child is 5 years of age and the perpetrator or the pedophilic is 11, 12 years of age, again that is considered under pedophilia. So it's a very strict guideline, and if these criteria are being fulfilled by the adult and they are engaging in sexual activity with prepubertal children, again children are defined as less than 18 years of age. So either heterosexual or homosexual, but if they are involved with a child, then it is called as pedophilia. Usually there is some component of sadism also, and this behavior may be either limited to incest or may spread to children outside the family. So what we have seen in most cases of pedophilia, the perpetrator is a uncle or some relative with whom the child is comfortable also. So when it is done by somebody who is related to the child, then it comes under incest, but it can be some other person also. And in most civilized society, pedophilia is a serious offense, and the convicted pedophile's name remains on a sex offenders list. And so that everybody is just aware that this is a pedophilic person. And in India, we have POXO Act, so it is Prevention of Sexual Abuse Against Children Act. So whoever person commits this act is then convicted under the POXO Act. So this was about pedophilia. Zoophilia, or what is also known as bestiality, it is a persistent and significant involvement in sexual activity with animals. So this is rare, but whenever animals are involved in sexual activity, then it is called as bestiality or zoophilia. Like I've told you, there is a long list of other paraphilias also. So the less common ones, like sexual arousal with urine, is called as urophilia, with feces is coprophilia, with enemas is clismaphilia, and with corpses is necrophilia. So maybe in your NEET or next whatever exam is going to be there, MCQs can be asked about these paraphilias. So they'll give you a description and they'll ask you what is the type of paraphilia, or they'll ask you the type of paraphilia, and in the options you'll be asked to describe what it is. So having an idea about this is important. Even if you don't see cases, MCQs are very commonly asked in these areas. Then one interesting thing is asphyxiophilia. So here enhancement of sexual experience occurs by cutting off blood flow through the brain. So the patient or the person strangulates himself or herself so that blood flow is cut, and then they have an enhanced sexual experiences, usually performed during masturbation. But yes, if you're cutting the blood flow, then a lot of other problems can occur, and the most dangerous of them is cardiac arrest. And estimated death rates according to APA is 1 person per year per million of population. So a lot of deaths do occur due to asphyxiophilia. So this is another paraphilia. Now, I've just uh, compiled all the causes of all the paraphilias. So, any type of paraphilia, why does this occur? It can occur if there is inability to access the normal sexual outlets. So, the patient is not able to go through a normal sexual intercourse, or what is the normal process. So, if they're not able to go, then they focus on other things like non-living objects and all. So this is one theory. Another theory is that early sexual fantasies may be repeatedly reinforced through masturbation, and then this ultimately results in paraphilia. So there are some fantasies, and the patient is giving into these fantasies or encouraging these fantasies, and then they can lead to such paraphilias. Some people say that it can be due to biological causes because it is seen mostly in males. So they say that higher testosterone can be one of the causes. Then there are some learning views. So they say that they say that fetishes can be conditioned. So they have done a lot of experiments, and they have also taken clinical histories, and they have seen that fetishes are learned. So they learn how to do this, and this learned behavior becomes part of their normal behavior. Now, treating is easier said than done. It is very, very challenging, very complicated. Full cure, I don't know if it is possible also, but we have to try. So what can we do? We can do either psychoanalysis and psychoanalytical psychotherapy. So if the patient is psychologically minded, patient is cooperative, patient has good ego strength, then we can do this type of therapy, because it involves a lot of cooperation from the patient also. The patient tells their childhood experiences, and then work through is done in probably 9-10 months of therapies. So because it's such a long drawn process, a lot of patience is required from the patient also and from the therapist also. Behavior therapy is easier comparatively to psychoanalysis. So in behavior therapy there is aversion therapy, and it is the treatment of choice in severe distressing paraphilias. But here also the patient should give consent. But if the patient is not psychologically minded, aversion therapy is good. So what is done in aversion therapy? Like for example, if they have a fetish for shoes again, so what they're done is they are shown a picture of shoe and then given a small current or a small painful stimulus. So what happens is that shoe gets conditioned with a painful stimulus. So whenever they think about shoe, they don't get a sexual arousal. They remember the electric shock. It's a very small shock which is given, or they remember the pain which was inflicted. So this can help in decreasing the paraphilic behaviors. Some drugs are there, and like I've told you, there's no cure, so you can't give a drug like a antibiotic and cure it like an infection. But sometimes we can give antipsychotics, because if there is a lot of aggression related with the paraphilia, then antipsychotics can work. So in this we can give. And benperidol was earlier believed to be useful, but now it is not used, not given, so that's not important. But we use a lot of anti-androgens. Like we have seen that probably high testosterone might be a cause for paraphilias. So if we give a drug which will decrease the testosterone or decrease all the androgens, it might be used. So the sexual activity at least comes down. But again, it's not a cure. So depending upon the patient, you can give antipsychotics, you can give anti-androgens, at least try any or some type of therapy which might work. Usually we give a combination of drugs and psychotherapy, but again, very, very challenging to treat these cases. So I would just like to conclude that it is important to understand that not all paraphilias are harmful or distressing to the individual. So if the individual are able to incorporate in a healthy and consensual way, then it is not abnormal. But if there is distress, harm or impairment in functioning either to self or to others, then it is clinically significant. It requires some intervention, some treatment which is possible, but it is abnormal and treatment should be started as soon as possible. Okay, so with this we finish paraphilias.
So today we are going to discuss about LGBTQIA plus community. What is this and how it is related to the psychiatry and psychosexual issues. The relevance of topic is certain uh, transgender communities were considered as psychiatrically ill and also considered uh, have criminalizing imposition because of some act, and these were included in the psychiatric disorder also in both ICD-10 and DSM-4. But some changes are there for the last 10 to 20 years. Some developments are there. We will learn what is LGBTQ orientation and the psychiatric aspect of it. LGBTQ stands for L for lesbian, G for gay, then bisexual, transgender, queer or questioning, intersex, asexual, and plus is more. These terms are used to describe the person's sexual orientation or gender identity. One by one, we will go through the all acronyms. L for lesbian is a women to women aligned person who is attracted to only people of the same similar gender. G for gay usually refer to men and men aligned individuals, but lesbians can also be referred to as gay. The use of term gay became more popular during the 1970s. Bisexual is which indicates an attraction to all genders, whether it is male or female. The recognition of bisexual individual is important since there have been periods when people who identify as bi have been misunderstood as being gay. So they have attraction towards both the genders and may be considered as gay, but it is not. Bisexuality has included transgender, binary and non-binary individuals since the release of the Bisexual Manifesto in 1990. So in transsexual, uh, the people experience a gender identity that is inconsistent, and in addition to it, they desire to permanently transform or transition to the sex or gender with which they identify themselves. For example, a boy is feeling like girl. If they wish to or want to change permanently to the that sex is known as transsexual. There is a term gender dysphoria. A medical diagnosis of gender dysphoria can be made if person experiences marked and persistent incongruence. This is now in the scene in ICD-11 and DSM-5. We will learn about the developments in ICD-11 and DSM-5 later in the slides. The queer or questioning. This is an umbrella term uh, which defines as whoever is having identify themselves as of other sex, who is not anyone who is not non-cisgender or heterosexual. So it includes the lesbian, gay, asexual and transgender as a umbrella term for their question of their identity. Intersex is for the biological male and female who is not assigned XX or XY. There may be genetic variations like XXX, XXY, etc. And biologically they do not fit into the male and female. Their chromosome patterns, gonads, or genitals do not fit typically in binary notions of male and female. Asexuals are who has little or no sexual attraction. They have little or no sexual attraction. However, they may experience romantic attraction towards any orientation. Plus is used to signify all the gender identities and sexual orientations that are not specifically covered by the other 5 initials of LGBTQIA. For an example, two spirits, pan-indigenous, uh, maybe the different identity patterns which is not included in the first 5 terms. So LGBTQ has various variations in acronyms. For example, LGBTIQ, only A and I is not included. A and plus is not included. LGBTQQIP2SAA. It includes questioning, pansexual, two spirits, androgynous, additional to the LGBTQIA. There are variations. So regarding the history of the acronym is, so it is where the variety of orientation and identities are there. So previously there are few or less identities were there like gay or lesbian, but LGBTQI is more inclusive of other identities also, and the acronym is an evolving process. It may change in future also. For example, bisexual as defined by the Sigmund Freud originally meant a person was both a man and woman. Being both a man and woman is now referred to as bigender. So bisexual is turned into bigender. This is the evolution of the term and acronyms. The plus matters because of the same reason. Some of the orientation may not be included in the LGBTQ term. So this is for other persons who have identified themselves as a some other certain kind of uh, gender identities who may be inclusive of the same community. So there are related terms also like cisgender. Cisgender means the gender associated with the sex they were assigned at birth. Means XY identifies herself as female and XX identifies herself as female and XY as male. So this is a common pattern, cisgender. Non-binary means a person whose gender identity is neither exclusive women or men. This is an umbrella term. And gender non-conforming also like non-binary. Pansexuality and omnisexuality is for the people who feel attracted to other people regardless of their biological sex, gender and gender identity. So where is the pride hidden in this community? So the issues were run along for years to identify themselves and to be inclusive in the general society, and they should be acknowledged, accepted and respected And in some countries this is there, but in some countries this is considered as a crime, and this is the where the crime this is considered as crime are located in the Middle East, Africa and Asia mostly. In 11 countries the death penalty is imposed or is at least a possibility for same-sex sexual activities. So, however, criminalization is not the only reason why many LGBTQ people cannot express their sexual orientation. There are societal rule and connotation and notions are there regarding them, and what they feel like they are neglected, discriminated, and so many uh, the things are being happened to them because of their gender identification. So, where we are regarding the acceptance of the homosexuality. So, here are the few points. So, it is higher in the Western European countries like Canada and Australia. Among these countries, over 80% of respondents taking part in recent survey believed that homosexuality should be accepted by the society. So, the people who are more in the favor of accepting them uh, are seen to have left-wing ideologies, are more educated and who are not strictly very religious. Over the last year, there has been positive change in the acceptance homosexuality in the world. Amongst 27 countries surveyed, South Africa and India recorded the highest increase in the acceptance of homosexuality in the society. So, increase in uh, the pattern is more seen in the South Africa and India. Not only the South Africa, the countries like Tunisia, Nigeria and Kenya recorded an increase in the acceptance as well. So acceptance is increasing, but this is not the case scenario that they are openly inclusive into the society, and they are not liable for exclusion and violence because of their orientation. Between these countries, Nigeria remains one of the most dangerous countries for the LGBTQ people in the world. In Spain, people are more likely to support a family. Another study conducted in Singapore shows that about half of the respondents said they would be likely to react negatively to a close family member coming out. In Japan, most LGBTQ people said they have not disclosed their sexual orientation. So things are 50-50, hai na? We are accepting it, and there is a hitch in the expression of their gender identity because of the issues. So the term acronym LGBTQIA plus is there, and when to and how to use it. This is an umbrella term. Every person belongs to this community, should not be addressed like LGBTQIA. If the person is transgender, one should use the X is transgender, not the X is LGBTQIA plus. The impact is raising the visibility of the marginalized group. The visibility of this group is now more. They have more in number because of the they have included in the one term of their different orientation. So they are not scattered, but they still face considerable homophobia and discrimination. Harassment, bullying, and workplace discrimination are not uncommon. In the impact, one advantage of utilizing a unified terminology is the ability to engage in political advocacy. Social solidarity is there between this community. Unifying terms like LGBTQIA+ can help people feel connected to a larger group. There are actually many individual communities made up of diverse individuals. These communities have something in common, but each identity has its own unique experience and needs, and they are now included in the one term. The challenges are not everyone agrees, but the LGBT is still prevalent in use rather than of LGBTQIA. The four-letter acronym is simpler way. Some people find that it is the simpler way, but some people find left out because of the non-inclusiveness of QIA plus in the LGBT. Okay. So terminology is a continuous process of evolving. We are now at the LGBTQIA plus. The importance are to improve visibility of this community, recognition and acceptance, but still they continue to face discrimination and they are frequent target of social and economic marginalization as well as harassment and violence. What about the numbers? How many they are? According to a survey conducted in 27 countries, 7 out of 10 people identify as heterosexual. This means around 3% of respondents declare to be homosexual, gay or of other uh, gender identification. Additionally, 1% are pansexual or omnisexual. This means attraction towards all the genders. In Indian perspective, if we go into the history during the Mughal Empire, a number of the pre-existing Delhi Sultanate laws were combined into the Fatwa-e-Alamgiri, mandating several types of punishment for homosexuality. This could include 50 lashes for slave, 100 free for a free infidel, or death by the stoning for a Muslim. In the British era, in 1884, a court of North India ruling on the prosecution of so-called as hijra or transgender, the court commented that physical examination of the accused revealed she had the marks of a habitual catamite and commended the police desire to check these disgusting practices. And after this, in 1871, the British labeled the hijra population as criminal tribe. So this was the thought during that era. What happens at that time also, the codification of criminalization of homosexual activity under the section 377, which stood for more than 70 years after Indian independence also. During the time, the Goa Inquisition, one prosecuted the capital crime of sodomy in Portuguese India, but this was for gay activity, but not for the lesbian activities. The British Empire criminalized anal sex and oral sex for both the gender identification under the section 377 of the Indian Penal Code. We will talk about the decriminalization of 377 also. So what about their rights in India? So LGBT people in India are afforded greater protection than those in many other Asian countries. So we are more forward regarding the LGBT people amongst the Asian countries. But still they face the social and legal difficulties not experienced by the non-LGBT people. According to the current scenario, there are no legal restrictions against gay sex or gay expressions. Same-sex couples have equal cohabitation rights, colloquially known as live-in relationships, is now recognized by the Honorable Court. However, India does not currently recognize same-sex marriage. Marriage and live-in relationship are two different things. Marriage is not recognized, but live-in is recognized. Some states protects traditional third gender population in South Asia through housing programs and offer welfare benefits, pension schemes and others. And there are approximately in India 4,80,000 transgender people as per the census 2011. So In the 2010s, LGBT people in India increasingly gained tolerance and acceptance, especially in large cities. So there are developments regarding their acceptance for the last 2 decades. So this is the very important about the NAS Foundation. The NAS Foundation Trust is an NGO that works on HIV/AIDS and sexual health, uh, and also for the people of different orientation and those who are impacted by HIV and AIDS. The foundation works for them, and the same foundation, it is a Delhi-based organization that has been a forefront of the battle against Section 377 of Indian Penal Code to decriminalize the Section 377. So it was the main petitioner, and the foundation found the code as a unconstitutional. In the same matter, the Delhi High Court observed that the point one is consensual sex amongst adult is legal, which includes even gay sex and sex among the same sexes. They said the law violates Article 14 of the Constitution, which guarantees the equality. Article 15, which prohibits discrimination on the ground of religion, race, caste, sex, and place of birth. Article 21 for protection of life and personal liberty. They have concluded that this should be decriminalized. But what happened then? Ministry of Home Affairs expressed its opposition to the decriminalization of homosexual activity, stating that in India homosexuality is seen as being immoral. So the central government reversed its instance on 28 February 2012, asserting that there was no legal error in decriminalizing homosexual activity. But in 2013, the Supreme Court set aside the 2009 Delhi High Court rule within its jurisdiction. Further, the same the Supreme Court of India dismissed the review petition filed by the central government, the NAS Foundation, and several others against its 11 December verdict on Section 377 by the High Court. The bench explained and concluded that while reading down the Section 377, the High Court overlooked that a minuscule fraction of country's population constitutes lesbian, gay, bisexual, or transgender people, and in more than 150 years past, less than 200 persons have been prosecuted for committing offence. This cannot be made a sound basis of declaring the section ultra vire Article 14, 15, and 21. On the basis of number of prosecutions and the cases, they have decided that and reverse the verdict of High Court. Again, the matter was taken to the National Assembly, and it was rejected by the Assembly by the vote of 71 and 24. Now what happens is, on 2nd February of 2016, the Supreme Court decided to review the criminalization of homosexual activity, and in 17, Supreme Court unanimously ruled that the right to individual privacy is an intrinsic and fundamental right under the Indian Constitution. The court also ruled that the person's sexual orientation is privacy issue, giving hopes to the LGBT activists that the court would soon strike down the 377. Now they were against their own decision. Finally, in 2018, the court unanimously ruled that Section 377 is unconstitutional, and decriminalization of 377 was done. So this was the history of decriminalization of 377. What next is recognition of same-sex relationship. So as I have said, the live-in or cohabitation is allowed, but same-sex marriage is not recognized by the Indian law. Okay. By this law, the Uttarakhand High Court in 2020 acknowledged that while same-sex marriage may not be legal, cohabitation and live-in relationship are protected by the law. Here are a few points in the Article 15, which is in the favor of decriminalization of 377, but no need to read all the matter. So other things which are in the pursuit of this act is decriminalization and bullying in higher education of this community. In case of Navtej Singh Johar and Union of India, it bans discrimination based on the sexual orientation, and in other, discrimination on the basis of gender identity is constitutionally prohibited. But in military services, the thing is not in the favor of decriminalization of 377, and the bill was lapsed in the Lok Sabha. So, transgender rights. For transgender rights, one have to define the definition of transgender person, and this is the definition of transgender person: one who is partly female or male, or combination of male and male, or neither female or nor male. In addition, person's gender must not match the gender assigned at birth and include trans men, trans women, person with intersex variation, and gender queers, and person having socio-cultural identities such as Kinnar, Hijraz, Aravani, and Jogta. So this is the legal definition of transgender uh, persons. So what happened after the verdict? So in 2014, they were declared socially and economically suppressed class entitled to reservations in the education and jobs, and mandates the recognition of third gender on official documents like voter ID card, passport, bank forms, and have started providing a third gender option in uh, legal documents or in the forms. So here is the bill regarding the Transgender Persons Protection of Right Bill, which was enacted in 2019 as Transgender Persons Protection of Rights Act. Their rights are protected under the law. So here are the few examples. One has contested the election in in Tamil Nadu Legislative Assembly, and one gave the examination of TNPSC. So these are the outcomes. Some are working as advocate at the Honorable Supreme Court of India. Some are filmmakers, some are writers, some are authors. So because of this, they are more included in the society. So what we talked about till now is somewhat related to Indian with the psychiatry also. And after the verdict came in 2014, the Indian Psychiatric Society recognizes that there is no evidence to prove that homosexuality is unnatural. And finally, they said no evidence to substantiate the belief that homosexuality is a mental illness or a disease. And they also said in 2018, certain people are not cut out to be heterosexual, and we don't need to castigate them, we don't need to punish them, to ostracize them. Because this was included in the ICD-10. So after the verdict, they have stated that this is not the illness. So what is happening for the same-sex marriage? There is a survey by Ipsos, which is a surveying company, and they found that 44% of Indian people were in the favor of legalizing the same-sex marriage, and 14% of Indians were in support to allowing some kind of legal recognition of the couple. 18% opposed, and 25% were not in any opinion. So developments are the LGBT community The issues are raised for the marriage and adoption rights, but Supreme Court held that it is the matter to be decided by Parliament, and judiciary cannot frame law on this subject. So it is under debate and under the development, the recognition of marriage. These are the summary of rights they have. Same-sex sexual activity is legal, yes. Equal age of consent, yes. Anti-discrimination laws in employment, it is yes. Anti-discrimination laws in provision of goods and service, yes. And same-sex marriage is no. Recognition of same-sex couple is yes, as live-in couple. Stepchild adoption by same-sex couple is no. Adoption by LGBTQIA is yes. Joint adoption by same-sex couple is not allowed. International joint adoption by same-sex couple is not allowed. Access to in vitro fertilization for lesbian, it is allowed. Commercial surrogacy for this community is no. Altruistic surrogacy is no. Automatic parenthood on birth certificate for children of same-sex couple is no. Right to change legal gender is yes. Coverage for sex reassignment surgery is yes. Intersex minors protected from invasive surgical process, banned only in state of Tamil Nadu and pending in Delhi. Third gender option is yes. Anti-discrimination law covering gender identity and expression is yes. Trans women protected under Domestic Violence Act is yes. Homosexuality and transgenderism, which is related somewhat to psychiatry, is homosexuality is declassified as illness is yes. Transgenderism declassified as illness is yes. They are not allowed to serve in the army. Conversion therapy is banned. It is somewhere is allowed and somewhere is not. MSM allowed to donate blood? No. No. Male having sex with male. MSM is the short form of this. So coming to the psychiatric aspect, in ICD-10 we identified the gender identity disorder under which transsexualism is there, dual role transvestism, gender identity disorder of childhood, others and unspecified. Similarly in DSM-4, the gender identity disorder is recognized as a psychiatric illness. So this is the development in DSM on the timeline. When DSM-2 was there was no diagnostic category for gender incongruence. In DSM-3, transsexualism and other was included. In R, again they have included some and declassified some of the illness. In ICD-10, there is gender identity disorder of childhood is there as illness. Dual role transvestism, transsexualism was there. In DSM-4 TR, it was there. What happens in DSM-5 is it is replaced by gender dysphoria in adolescents and adults. Gender dysphoria in children, and in ICD-11 it is incongruence of gender in childhood, adulthood or in the adolescence. So you can see that the term identity disorder is replaced as dysphoria and incongruence in ICD-11. What does it mean? We will discuss further in the presentation. So in the past, gender identity disorder was a recognized disorder in psychiatry, which had many aspects of it like comorbidities and their classification, their diagnostic criteria, and the therapy is also treatment also suggested by the group of experts like psychotherapy, hormonal therapy, and sex reassignment surgeries. What happens in ICD-11? ICD-11 has replaced gender identity disorder as gender incongruence. It has many subtypes: gender incongruence of adolescence or adulthood, incongruence of childhood, and unspecified and others. So here are the terms: identity, congruence, and dysphoria. So one should understand what does it mean and how we recognize the disorder as congruence or dysphoria as per ICD-11 and DSM-5. So identity, you all know that identity is being male or female or something else, is gender identity. Expression is how they express their identity by means of clothing, physical experience, and external presentation of the behavior. The incongruence is the person's marked and persistent experience of incompatibility between the person's gender identity and the gender expected of them based on their birth assigned sex. So, incongruence is somewhat discomfort and distress. And if this incongruence, this identity not accompanied by the distress and discomfort, if the identity is stable, then this is not a disorder. If the incongruence is there, dysphoria is there because of that identity, then only we can recognize them as a disordered person. So coming to the ICD-11 again, the diagnosis of gender incongruence was included in ICD-11 to preserve the access to health services, but it was moved from ICD-11 chapter on mental and behavioral disorder to the chapter on sexual health. In ICD-11, uh, the term which was used in IC-10 like opposite sex, anatomic sex are abandoned, and the word which are being used as experienced gender or assigned sex to remove the binary and stigma. In ICD-11, gender identity is characterized by a marked and persistent incongruence between an individual's experienced gender and the assigned sex. You are getting the point, the marked and persistent incongruence. There is different identity, but incongruence is there. Acceptance is not there. The person is not normal with that identity, not firm with that identity, not stable with that identity. The person is incongruent. He find himself, a male is find himself as a female, but he is not happy with that. He is in discomfort. He is in incongruence. Again, the gender variant behavior and preferences alone are not basis for assigning gender identity diagnosis. So the thing which was there in the IC10 like fetishistic transvestism and dual role transvestism disappeared in ICD-11 because these conditions involved consensual and solitary sexual activities, cause no inherent harm to self or others, and are not necessarily distressing to the individual or associated with functional impairment. What is transvestism is? Gaining the sexual gratification by wearing clothes of opposite sex. This is not the disorder of gender identity. है ना? They consider themselves as male and female, but they are gratified by the opposite sex clothing. So after ICD-11, what happens in DSM-5? This is the diagnostic criteria. I won't read it. You know. This again the criteria. So the last line, in addition, the condition must be associated with clinically significant distress and impairment. So these are the keywords: distress and impairment. In DSM-5, being transgender is not considered per se a psychiatric disorder. It is only the resultant dysphoria that justifies a diagnosis. If dysphoria is there, then the diagnosis, otherwise not. While dysphoria was chosen for the diagnostic title, the word incongruence is used for the definition in criterion A. The DSM-4 TR criterion A request is cross-gender identification. Further, in DSM-5, the criterion was modified in order to avoid a male-female dichotomy, and the expressed gender can be female, male, in between, or otherwise. Similar thing. Same thing, you know. Similarly, in DSM-5, the term transvestic has nothing to do with the gender, and disorder is part of section on paraphilias. Same idea with that ICD-11. Now, what is the guidelines of National Medical Council regarding this area? Now, you all may know that now we have a CBME based teaching module, which is competency based medical education. So, they have uh, given the idea what one should learn after in the psychiatry, and as a course at the end of this course the student will be able to what they will be able to demonstrate the ability to assess the gender identity of an individual and distress caused due to the individual's own gender identity in simulated environment. This should be learned by the student. So they have changed their curriculum also. In this course, describe and understand how to discuss sexual orientation, sexual identity, gender identity, as well as intersex identity as a part of routine history taking. Further, demonstrate the ability to educate and counsel individuals or family members about intersex variations and regarding the whole part, and demonstrate knowledge that conversion therapy practice for sexual orientation or gender identity or on people with intersex variations is unethical. Describe and understand gender identity, the biological and gender binaries, rejection of gender binary, gender non-conforming, gender non-binary, androgynous and other identities. Demonstrate the ability to educate an individual and family member that gender incongruence by itself is not a disorder, does not require any clinical intervention. Any form of conversion therapy is unethical. You may find such a patient in your clinic, whether you are in the field of ops and gynae, in plastic surgery, in surgeries, or you, as a urologist, you may find such a patient in your clinic. So you must be aware of these facts. What we are now have the idea regarding this gender identity. One must be able to describe difference between gender incongruence and gender dysphoria. Discuss situations where there is role of mental health support in gender dysphoria, that is discussing with family, deciding on hormonal treatment, sex reassignment surgery, and so for the summary for this session, we now know that LGBTQIA is a legally recognized community. Section 377 has been decriminalized. Various rights are reserved under Constitution for them. The status of marriage is not provided in Indian context but recognizes live-in relationships. Gender identity is replaced by incongruence and dysphoria in classifications. ICD-11 considers child, adolescents, and adults for gender incongruence, and DSM-5 includes, but with a must requirement of distress and impairment, which is similar for both the ICD-11 and DSM-5. Incongruence means there will be a connotation of distress and impairment with it. So in the last, thank you.